Okay. Hi, everyone. Good morning. Thank you so much for joining us for Lupus LA's latest on lupus patient conference. We have a very large audience live streaming, so just know you're all not in this alone. We appreciate you being here today. And before we get started, I just wanted to communicate with the live streaming audience that we are offering live interpretation in Spanish. So you need to find the globe on the bottom of your Zoom page. Once you click on it and choose Spanish, you will hear real-time live interpretation. If you have any trouble connecting, please email us at info@lupusla.org and somebody will respond to you. Here in the room, you each have a folder with an agenda, speaker bios, information about Lupus LA patient programs. You'll also find a survey, and we ask that you fill it out and drop it off on your way out. We do read everyone. A lot of the programming we do both virtually and in person is by your suggestions from the things that you're looking for, your gaps in care, the specialists you're unable to see. So please fill those out. They're extremely useful for us. You'll also find a notebook, self-explanatory, and a white index card. The white index card, for those of you new in the room, is for a lightning round Q&A that Dr. Wallace does. And we ask that you put your questions down during his talk. We'll collect them and he'll answer all of your questions. There's also a flyer in the folder from Fate. I can't talk. From Fate Therapeutics, one of our sponsors here today. They'll be speaking a little later and they're sharing some information about their clinical trial. So please read over that. And on the back is how you can get in touch with them and the locations of their trials. They also have a table, as well as AstraZeneca, another sponsor. We encourage you to go to their table, get some information from them during lunch or when the conference is over. If you don't already follow us, please, all digital platforms are at Lupus LA. We encourage you to stay connected to learn about our virtual programs, our patient conferences, clinical trial information, events, and the latest on lupus. We have an amazing program today with expert speakers who, again, you can read their bios in your folder, so we don't have to do that for you. We're also excited to invite a few of the members of our Patient Advocacy Panel. So we created this panel last year for a group of women that, they're a group of women, a diverse group of women comprise this panel. Each has their own lupus journey, and that's the last hour. We hope you stay for that discussion. We also have 3 raffle opportunities for in the room and 1 live streamed, which we'll select after. They each have a little bit of Lupus LA swag and a $100 gift certificate. So we encourage you to stay. You have to be in the room for that drawing at the end of the conference. Okay, so we hope that you enjoy the program today. It is my pleasure to introduce our first speaker. He is the founder of Lupus LA. An emeritus board member, a world-renowned rheumatologist, the member of our medical advisory board, Dr. Daniel J. Wallace.
Thank you.
Do you want to use this?
Oh, okay. Can everybody hear me? Okay. So I understand we have about 200 people that have signed up for the streaming and probably thousands that will hear it. So we will be passing out 3x5 cards so that you can ask poignant questions, and we will be able to learn more about lupus that way. I've been asked to talk about new approaches to lupus. I saw that Jennifer and Maureen and other lupus speakers, Fate, are talking about different aspects about treatment of lupus. I decided to pick out about 10 topics that are not on their subject matter, and we'll go through that are new and relevant. Let's see, how does this go? How do we go forward here? Okay. So Lupus is a pleomorphic disease. It's more of a spectrum than a disease per se, and understanding its immunologic context is critical towards what you're going to hear about later with translational developments with new treatments. So we have a group of people that have the genes for lupus, and in combination with certain environmental stimuli, this activates the immune system and causes the formation of autoantibodies. And these autoantibodies then percolate through the bloodstream and cause a certain amount of damage. And lupus has a multifaceted pathogenesis where, again, the predisposition leads to environmental changes, which leads to first benign autoimmunity and then pathogenic autoimmunity, which leads to the activation of certain pro-inflammatory factors such as cytokines, interferons, and antibody production, which then activates B cells and T cells and leads to lupus, which ultimately causes tissue damage. So over the last 45 years that I've been involved in lupus, despite improvement in survival rates, lupus remains a chronic disease with a higher than expected mortality rate. Even though over the last 30 years we've improved life expectancy, it still has a very high morbidity and mortality. And most of the improvements in lupus survival were in the 70s and 80s, and in the last 20 to 30 years, it hasn't been as much. But the survival is much worse than in the general population. So even though we have lots of blood tests that look for lupus activity, we have SED-rate, we have CRP, we have complement, we have anti-DNA, we have about a third of all lupus patients who accrue permanent damage and fibrosis and scarring within 5 years of diagnosis, even with minimal abnormal blood tests. And this is from some work done here by Ram Singh at UCLA, that lupus is an underestimated cause of death. It is very, very high on the scale of demise in people of color and people as well as males, and is very high in the number of causes of death of people in their second and third decade. So these are the 10 topics I chose. Let me move over here so I can see this a little better. I just wanted to go over 10 bullet points, and then we'll have the rest of the time to go over the questions. And these are new insights in the last couple of years. First of all, let's go through genetic factors. About if you have lupus, about 10 to 12% of lupus patients have an affected first-degree relative with lupus. And from work at USC done about 20 years ago and confirmed that if a woman with lupus is one of an identical twin, her twin sister in her second or third decade has a 20 to 30% chance of developing lupus. So there's a genetic component in addition to an environmental component. And many different gene products contribute to lupus susceptibility. And what I'm going to talk about now is a new development that we're working on at Cedars-Sinai called monogenic lupus. Monogenic lupus is where, rather than 50 or 60 different genes causing the disease, we have one gene. And monogenic lupus is responsible for about 10% of pediatric lupus. And the one we're working on at Cedars-Sinai is Copa syndrome. And it represents an enriched group of lupus patients who have a single gene that causes the disease. Most of these emphasize certain proteins known as interferon, complement deficiencies, or autoimmune lymphoproliferative processes. And if there's one gene that causes lupus, this makes it easier to find out the cause and ultimately the treatment of lupus. So monogenic lupus is a distinct variant. It is characterized by being early on in family clustering. It is more severe. It tends to affect the lungs and the kidneys. There's probably about 30 genetic variants of monogenic lupus that disrupts the immune pathway through triggering B and T cells and altering tolerance. So we have a center where we have a few families with Copa syndrome, which is a form of monogenic lupus, and we're trying to fast track new treatments through a series of grants we have, which will allow us to better understand the disease. There's also recent evidence of environmental factors that cause lupus. We know that there is evidence that air pollution and particulate matter can increase the risk of lupus, that there may be certain lupus clusters in areas of increased pollution. We know that lupus patients who smoke have increased risk of more severe disease. They are less tolerant of antimalarial drugs. And lupus patients who smoke tend to have more serious skin disease. There's a variety of pesticides used in agriculture, which are associated with lupus. We also know from some work done at Harvard that psychosocial stressors can alter the B and T cell reactivity and the immune system. And the other more important aspect of environmental associations is what we call the microbiome or diet. So some of the factors associated with lupus that are environmental are cigarette smoking, oral contraceptives, heavy metals, air pollution, ultraviolet light, silica, infections, and even vaccines. And there's a number of factors that can trigger skin lupus, especially subacute cutaneous lupus, which is a specific rash, such as proton pump inhibitors that are used for heartburns, certain drugs used for blood pressure, antibiotics, some chemotherapy agents, ultraviolet radiation, and radiation therapy are all factors that can increase the risk of environmental aspects in promoting lupus. So the microbiome is gut bacteria, and gut bacteria is universal. And in lupus, we know that they tend to activate T cells and promote autoimmune activity. This has also been demonstrated in a variety of other autoimmune conditions, such as psoriatic arthritis and inflammatory bowel disease. But there's some recent work that suggests that the presence of gut bacteria is associated with greater activity, and which leads to what we call less biologic diversity in lupus patients. And stool from lupus patients sort of confirm what used to be called in the 80s the leaky gut hypothesis, that demonstrates that some form of bacterium can enhance adaptive immunity expressions, and that mice with lupus have altered DNA repair, and as a result, there are. Can you get me some water? Yeah. There's some evidence that there may be a lupus diet, whether it's hypomethylated diet, whether it's one that promotes eliminates the T cell diversity issues. And this may have something to do with treating lupus, and there may be a lupus diet. So lupus evolves over a period of time. In the what's it? In the 1990s, the military started a study from their Department of Defense database in Oklahoma that showed that when all recruits that were put in the military, inducted into the military in the 1990s, had blood drawn. And a certain number of these people developed lupus over the following 10, 20 years. And what the investigators did was that they then looked back retrospectively at those who had volunteered for the military and ultimately developed lupus and looked at how this happened over a period of time. And what they found was that first there was a process called benign autoimmunity and then pathogenic autoimmunity, where let's say anti-SM, anti-RNP, anti-DNA, and a host of other autoantibodies evolved over time. And this led to ultimately the development of full-blown lupus with a clinical illness. So the question is, how can we halt this evolution in lupus? Well, we could start by altering genetic presentations. We might be able to vaccinate people to prevent lupus. We could give them an improved diet with manipulating the microbiome. We can eliminate environmental exposures. But then, how does lupus manifest itself, and how can we prevent that? I'm of the belief that the overwhelming majority of lupus right now stems from two aspects. One is inflammation, and the other is vasculopathy. And the treatment of inflammation is fairly straightforward. It's anti-inflammatories, it's corticosteroids, it's immune suppressants, it's biologics. But also the vascular tree plays a huge role. So a group at Duke in about 5 years ago evolved what they thought was two types of presentation in lupus. One is type 1 and the other is type 2. Type 1 is autoimmune inflammation, and it's the obvious one. It's the swelling, it's the edema, it's the rashes, it's the fevers. And this responds to steroids and anti-inflammatory therapy. But there is a type 2, which can exist by itself or in combination with type 1, which is a non-inflammatory condition that does not respond to steroids or standard immune suppression. This is the aspects of lupus that is concerned with fatigue, diffuse or widespread pain, brain fog, cognitive dysfunction, poor sleep, depression, anxiety. And it can occur with type 1. And some of the monogenic lupus that I mentioned already is part of this. Now, there's no good blood tests to determine who has this and who doesn't. But in rheumatology clinics, these patients also confuse the picture because they have diabetes, they have hypertension, they have hyperlipidemia, they have other comorbidities causing these symptoms. So the consequence is that all too often we see people with type 2 disease being given anti-inflammatories that they don't respond to. And there's a lot of work that's been done in this area. We know that there's three parts of the nervous system. There's the central nervous system, the peripheral nervous system, and the autonomic nervous system. And the central nervous system is the brain and spinal cord. The peripheral nervous system allows you to move your arms and legs and feel things. And the autonomic nervous system controls your pulse and blood pressure by opening and closing blood vessels. It's sort of like, think of your circulation as like a garden hose. So we call it Raynaud's, where you have in the hands, you pink up when it's warm and you turn blue when it's cold. You have Raynaud's of the brain with what we call vasomotor instability, where sometimes you're dilating, sometimes you're constricting. If you dilate too much, you get migraines. If you constrict too much, you can get a cognitive fog. And SID rates and CRPs are rarely abnormal, and they do not improve with inflammatory regimen. And this is present in the majority of lupus patients to varying degrees. A variety of imaging studies have shown and documented this in different types of functional MRI scans and small fiber neuropathy biopsies and sweat gland pathology have documented this. But work from New York with Betty Diamond has shown that some of this is associated with a specialized type of anti-DNA antibody receptor that enhances signaling and is critical in learning and memory, and with prolonged stimulation can lead to increased calcium flux and the death of neurons. And this is seen at about 30 to 40% of lupus patients, where in the blood-brain barrier, there's more activity here. And a certain type of cells in the spinal column called glial cells or microglia, which were previously thought to be just inert and didn't do anything, make cytokines and certain proteins which elevate inflammation in lupus and alter permeability. So by destabilizing the blood-brain barrier, we get more inflammatory mediation and from more stress. One of the newer, we've had lots of blood tests that look for lupus over the years, but the whole things of omics, what we call, has changed the ability to detect lupus activity in the way of subsets. In other words, can we identify a subset of lupus that's going to respond to a specific intervention? So omics is the collective characterization and quantification of sets of biologic molecules and investigates how they translate into structure, function, and dynamic of an organism. And these are what we call endotypes. These are subtypes or subgroups of lupus. There are lupus patients who have more T cell activity, lupus patients that have more B cell activity, lupus patients that have more cytokine activity. And there's currently a lot of omics initiatives in lupus that are ongoing. The only one available to the people in the room here would be from Exogen Laboratories, which a lot of your doctors may send their blood to. But the goal is to identify which lupus patients would respond to medicines before treating them. In other words, how can we tell in advance if you're going to respond? So using something called RNA-seq or RNA-based precision medicine, using different endotypes and subgroups, we can map out the proteins and the RNA sequences of these molecules and say, well, this person is going to respond to a T cell intervention, is going to respond to a B cell intervention. And this is really very, very exciting. Now, how do they do that? They do that through something called by regulating the immune dysregulation in organ systems. And this is done through thinning the antiphospholipid antibodies, where we address what we would call sticky blood, complement, which is a protein that is responsible for inflammatory activity, lupus specific antibodies, and these work on a variety of clinical domains. So where are we with targeted therapies in lupus that you're going to hear more about? There are agents that block T cells, B cells, complement, cytokines. There are agents that deal with the innate immune system, the adaptive immune system, tolerance to immune attack, and cell surface receptors. And you're going to hear that, and I'm happy to talk about specific drugs, that using these 7 or 8 different pathways, we are now able to target treatment in lupus. And as a result of some of this, EULAR is the European League Against Rheumatism, and it's the European counterpart to the ACR, which is the American College of Rheumatology. And they had a consensus group in which their three key recommendations last year, 2 years ago, which is game changing from what we've been doing for the last 40 years, is number one, we got to taper steroids because steroids are pro-fibrotic and promote scarring and damage. We also should use, we should initiate biologics earlier. In other words, normally with lupus, we would give a non-steroidal like Advil or Aleve, then we would go to antimalarials, and then we would go to corticosteroids, and then if the patient still had active activity, we would go to immune suppressives such as methotrexate, mycophenolate, or azathioprine. But if the person still had active activity, then we would go to a biologic. The difference between an immune suppressive and a biologic is an immune suppressive kills all cells, both good cells and bad cells. A biologic is a smart bomb. It just kills a specific interaction. So the EULAR recommendation was, let's not use the immune suppressive so much. Let's go to the biologic first because they're safer. And also for lupus nephritis, there are several new drugs such as voclosporin, obinutuzumab, which you're going to hear more about, which are specific for lupus and Benlysta being approved for that. And so the recommendation was be more aggressive with the newer drugs for lupus, try to spare steroids to prevent damage, and use the biologic first rather than the immune suppressive under most circumstances. So this is how they do it. It's a little confusing, but you can hopefully get a copy of these slides and go through them yourselves. So lupus has many, many different immune abnormalities, and I'm not going to go through them, but they address at least 10 different immune arrangements, which are listed here that I'm not going to go through. And what we need to do is have some influence on them. I want to talk about three other aspects that have come out of nowhere in the last couple years. One is GLPs. GLPs are your Ozempic, your Zepbound, your Wegovy, your Mounjaro. And as you can see, from 21,000 people in the United States taking it in 2019, we've gone up to several 100,000 people. And a lot of these people are people who have what we call metabolic syndrome, with or without diabetes. But what's been shown is that in addition to lowering A1C and helping weight loss and cardiovascular disease, these agents, or SGLT or GLPs, have a direct anti-inflammatory immunomodulatory actions. There are now papers showing that it helps osteoarthritis in the knees. There are now papers that show that these agents have an immune aspect that may well be anti-inflammatory. So in addition to the GLPs acting on the vascular system, the bowel, the heart, the brain, the eyes, the kidney, they also act on immune cells. They act on macrophages, lymphocytes, T and B cells, NK cells, eosinophils, and neutrophils. So so that is one of the others. The other is that I showed in the slide of new treatment approaches to lupus, agents of block complement. These are sort of in their infancy, but we know through certain laboratories, such as Exogen and other laboratories, such as Alkim's in St. Louis, that cell-bound complement activation products and activation of the the complement system is very important. And certain surface receptors of this, if we can block this, will play a huge role in ameliorating the inflammatory process of lupus. This complement activation is rarely found in other connective tissue disease. only 9% with Sjogren's, only 9% with rheumatoid, but a huge amount of especially the erythrocyte complement activation plays a role here. And these will be amenable to certain agents that are currently ongoing in clinical trials. So the other aspect is interferon, and we have a sponsor here today who has an anti-interferon drug for lupus, anifrolumab. And we know that type 1 interferon is a central driver in lupus pathogenesis, and it promotes innate immunity, it promotes cell damage, it promotes humoral immunity, and cell-mediated immunity, and these cause inflammation, disease activity, and damage. And when we release cytokines and we activate the interferon system, we have more disease activity. And there are several other drugs in exciting phase 3 clinical trials that are being looked at that will make a huge difference in the management of lupus over the next few years. Correlating with this is something called NETs, or neutrophil extracellular traps. This is like a spider web. It's a meshwork of fibers that traps immune complexes and promotes inflammation. This is actually where the original LE cell came from in 1948. And we know that these are that what these do is they're pro-inflammatory, and there are a variety of drugs. Andy Wright, who spoke at the last meeting here at UCLA, who used to be head of rheumatology at Children's Hospital of Los Angeles, is now promoting trials with a neutrophil extracellular trap, or NET drug. And we're seeing some very exciting new interventions which will complement the interferonopathies, the plasmacytic dendritic cells, and all these other actions. And finally, there's been a lot of changes in Washington in the last year, as you know. And as a result of this, we have to be smarter with designing clinical trials. Why can't we make clinical trials so that we get more benefit from them? In other words, let's say on the upper right-hand corner, you see a basket trial. In other words, instead of doing a trial for lupus, why don't we also study the same drug for Sjogren's, for rheumatoid, for scleroderma, for myositis, where we have one trial, one therapy with multiple diseases based on shared immunologic and pathology characteristics. Or let's consider an umbrella trial where we have one disease such as lupus, but we're dividing them into subgroups and risk factors, the omics. Or we could have a platform trial where we have one disease and we give multiple treatments with something called adaptive design, which means that if we discover that the intervention is not going to work in that subset very quickly, we stop it. So we simplify things. Or an adaptive trial where we do an early analysis rather than waiting a year or two for a result. So this is what's going on in Washington right now, where we need to work with alternative trial designs. So the benefits of the alternative trial designs is that we have a shared infrastructure and screening platform. We have a shared placebo or control group. We're flexible with addition or removal of arms. And we have comparative analyses so we can study different drugs. So these are some of the things that I'm involved with in my board work with lupus and Sjogren's advocacy organizations. It enables evaluation of a drug as a candidate for a specific target, and it accelerates drug development. There are, of course, some drawbacks. It's not as pure science as the others, but with what's going on, we have to do something. So to summarize, what are the 10 or the 9 new approaches that are improving our understanding of lupus? We're working with monogenic lupus rather than in addition to traditional lupus. We're looking at the environment. We're looking at diet. We're looking at not only inflammation, but vascular structure. We're looking at different subsets. We're looking at the GPLs. We're looking at complement activation. We're looking at NETosis and trial design. So I think I'll stop there. And these approaches will help us diagnose and manage lupus over the next few years, and they will add to new treatments, improving quality of life. So what I'll do is let you guys get your 3x5 cards, and we'll resume again in about 3 or 4 minutes.
Yes.
Thank you.
Please fill out the card, send it down, and we'll go through a little Q&A.
I'm sorry if I can't really see you. I had back surgery 6 weeks ago, so I'm a little gimpy here, but I'm okay.
Question. Comment?
Yep. How will the government cutbacks affect lupus research? It's very interesting. A huge percentage of lupus research is funded by the Department of Defense. And the reason is that half of all lupus women in the United States are African American, and a huge number of them are in the military. So far, hasn't affected that part at all, which is sort of really nice. I have a couple grants and they've not been affected so far, but there's a lot of court orders and there's a lot of issues that are going on, and anything could happen at any time. Do I recommend GLP-1 drivers for mild lupus? At what point would I give it? Well, I mean, these drugs are out of the system within a week, so there's nothing wrong with trying them. And if it works, it works. And if it doesn't work, you don't use it. There's a lot of people that have GI side effects. There's a lot of people that get depressed and anxious. And but it's another way of working with this. Okay. There are several new types of trials. Am I conducting any that are open now? Well, our sponsors here at UCLA are doing trials. I am doing trials. USC with Leanna Wise is doing trials. So contact your academic medical center and find out what is going on. Yes, we are still doing trials. And there are some private practice centers that are doing some pharmaceutical drug trials. And we have a sponsor here that's doing a CAR T trial that you will hear about. Are there tests available to know if lupus will attack my brain? Well, the problem is that blood tests aren't very good at looking at central nervous system lupus. Spinal taps are better, but we don't do spinal taps very often. And they're not going to, and the best way is a combination of symptoms, signs, laboratory findings, imaging studies, and all these issues put together in context will tell if lupus is attacking the brain. Okay. Should biologics ever be considered for patients with renal disease in remission, but with other symptoms such as fatigue and brain fog? In other words, if you've had nephritis, the nephritis is in remission, but you're still tired and achy and have brain fog, can you use a biologic? Sure, it depends on the manifestations and your other issues. Having renal disease in remission does not preclude that from happening. What is my opinion on using rituximab for treating non-renal refractory lupus? Rituximab is FDA approved for rheumatoid arthritis, so we know it helps that. We know that rituximab is very good for people with autoimmune hemolytic anemia. We know that rituximab is very good for people with low platelets. Unfortunately, the double-blind placebo-controlled study that looked at rituximab 10 years ago was poorly designed and did not show what it needed to show. But yes, all the rheumatologists in the room that you're here from all use Rituxan for a variety of indications. What do I think of CAR T therapy? CAR T therapy is a promising new approach that you're going to hear about for a full hour at 12 o'clock. And I'm not going to steal their thunder. And suffice it to say that it is a very novel approach. What is my best piece of advice for somebody living with lupus? Don't get angry, get even. That's my best advice. Be productive, join lupus advocacy organizations, and you will beat it. Does anybody in the audience have a question they want to ask me directly?
There are a couple of questions that are live streamed. One is it safe to be on both a biologic and an immunosuppressant?
Yes.
Does prematurity play any role in an increase in lupus?
Prematurity? I don't know what that means.
All right, that's it so far online. Okay. That's it. If anybody else were good in the room, any other questions, we'll thank Dr. Wallace, his time and his expertise. Oh,
Thank you. And I have no trouble sharing my slides with anybody. And you can certainly play back any portion if you want more information. And if you want to contact our center or any of the other centers here, the Lupus LA people will put you in touch. I'm happy to connect and go over any aspect of the condition with you. Thank you.
we appreciate Dr. Wallace. Wow. Thank you so much.
Sure.
I also want to add for everybody here that we also have a table outside with AstraZeneca, another partner here today, and Dr. Grossman and Dr. McMahon, who are speaking. They both have information about clinical trials. We also at Lupus LA have a clinical trial page, and a lot of our digital content is on clinical trial education, sharing available clinical trials. We don't recruit, but we do help our partners recruit. So please check in on, follow us online, look at our website. There's a lot of information and education in both places. It's my pleasure to introduce another member of our medical advisory board, also practices here at UCLA and has some information about a trial out in the lobby, Dr. Jennifer Grossman.
Thank you.
How's that for you?
And then you'll pull my slides up.
Click.
Oh, click. These aren't mine. So you're all getting to see my computer expertise right now. There at the end of the show. There we go.
No, it's all on the same slide deck.
It was all on the same,
You just had to go
okay.
through, yeah. Sorry.
And I messed up your system.
Yes, that's okay.
Not the first time, won't be the last. And then I just put forward.
Yeah.
Okay.
Right there?
Yep.
You can use the click.
Okay. Sorry about that. So I wanted to thank everyone for coming today and thank Lupus LA for giving me the opportunity to talk. When I was asked to talk, they gave me the chance to choose the topic. And when I was thinking about things, I wanted to talk about lupus nephritis because it's one of the complications of lupus that's one of our more severe ones and that we worry about as clinicians a lot. And because there were new guidelines for the treatment of lupus nephritis that came out in the fall. And these guidelines, I think, are a pretty big change from what we used and approached previously. And they require patients to take a lot more medications. And it's been a hard sell for me recently to try and convince people to start a lot of medications at the same time. And I think if you see the data and the trials behind it, it helps you understand the approach and why we think it's going to be better to take a lot of medications initially for better outcome. I know it can feel like you're kind of rattling around with pills, but that was the reason I chose this topic. Prior to getting into what the recommendations are, I was going to start off with just a little bit about a background of kidney disease and lupus. Can often be a little bit of a word soup where you're talking about classes and stages. And I recently had a drug denied because they were told that the patient had stage 4 lupus. And it's actually, she had class 4 lupus. And stage 4 lupus is when your kidneys are really not filtering the urine very good. And so backing up, the classes are what we see on kidney biopsy. So when you biopsy the kidney, we break it down into 6 different classes that can be seen. Class 1, we almost never see on kidney biopsy. There's really very minimal changes and a little bit of inflammation on the kidney. We don't typically see it on biopsy because these don't cause a lot of symptoms. We don't see much protein in the urine or red cells or blood cells, and it doesn't really require any specific treatment outside of how you would be treating the other aspects of lupus. Class 2 is minimal, is mesangial proliferative disease. And again, this is a milder form of lupus nephritis. There can be some red cells, a little bit of protein, and typically this one also doesn't require any specific treatment outside what you would be using to treat the other lupus problems. Then we get into the more inflammatory and problematic kidney lesions, and that's class 3 and class 4. And these are the proliferative, of course, I'm getting paged right now. And it will keep going off unless I hit it. Okay. Sorry about that. The class 3 is when it's parts of the kidney and not all of the kidney nephrons or functioning units that are involved. And class 4 is when it's really much more widespread. And these are the two types of kidney lesions that have a higher chance of going on to cause scarring and kidney failure leading to dialysis. So these, when we see these type of lesions on a kidney biopsy, we really want to jump on them and treat them very aggressively. Class 4 is membranous kidney disease, and these patients have a lot of antibodies in their kidneys and a lot of protein in their urine, but not as much inflammation. And because lupus is very complicated and special, some people have combinations on the biopsy, so it's not uncommon to see class 3 and class 5 or class 4 and class 5 on the same biopsy. Class 6 is what we're trying to avoid. So class 6 is the end stage of kidney disease where we see a lot of scarring and not as much active inflammation. And then just the stages to highlight the difference between class and stage. Stage is how good your kidneys are working. And this is what you're going to see when you see your blood work as it gets released to you. And you'll see stage 1, if it says the glomerular filtration rate or GFR is greater than 90. I think at UCLA's lab it says 60, or some of them say 60. That's normal. 60 to 90 is considered normal to mildly decreased. 45 to 59 is stage 3A. 30 to 45 is 3B. 15 to 29 is stage 4. And then if your glomerular filtration rate is less than 15, that's when you're getting more scarring and getting close to dialysis. And it's at that, when you hit about 15, usually it's when we're going to be referring you to get evaluated for a possible transplant. That's when the transplant centers will start doing the evaluation. How do you know you have kidney disease? A lot of the times, other symptoms of lupus are going to be active. So people will have rashes and joint pain, unexplained fevers. Those can all happen. But occasionally, the symptoms of kidney inflammation are a little bit more subtle, and other symptoms of lupus aren't present. So some of the things that you can see are leg swelling. And the leg swelling can get really bad, where you can leave indentations on the legs from the swelling, trouble breathing. And that can be from fluid building up around the heart or the lungs, because when you're peeing out protein in your urine, the protein in the blood goes down. Then that's on your blood test. You'll see that as albumin and also total protein. And when the albumin in your blood is low, it doesn't hold on to the fluid in your blood vessels, and that fluid leaks out into the tissues around. You can also see foamy urine, and I spent a lot of time trying to find what I thought was a good picture of foamy urine. I don't know how well that projects, because it's normal to have some bubbles in your urine. And that's one of the things, don't freak out about a little bit of bubbles. The foamy urine is really foamy. It looks like a beer head, and the bubbles stay there. They don't really go away. And the bubbles are present because of the protein that's there in the urine. Sometimes we'll also see the blood pressure rising. So I am a pain in the neck. When I'm doing video visits with my patients who've had kidney disease, I always want to know what their blood pressure is. And I want them to have a blood pressure cuff, because if I see the blood pressure rising, it's going to raise my concerns that the kidney disease could be getting more active. And it's also an important thing that we should be treating in people with kidney disease. When you're looking at your blood work And this is why we want to do labs regularly, is sometimes we're only going to pick up kidney issues by blood tests. And what we're looking for is to see protein in the urine. That dip that's done is not very accurate. That's like the screening test. I really think all lupus patients should have what we call a quantification or a more accurate measure of protein in the urine, which is the protein to creatinine ratio. The kidney doctors like to also do the albumin to creatinine ratio. So those are two things as you're looking at your labs I'd like to see. We're also looking to see if there's an increased number of red blood cells or white blood cells in the urine. Usually this is more than 5 per high power field. This is a little bit problematic because it's really hard to get a clean catch urine, and there's often some vaginal cells there, or infections can give these type of findings. So you have to look at the red cells and white cells in the urine in the whole picture. Just because you have an increased number of red cells and white cells, it doesn't always mean it's from inflammation in your kidneys. The creatinine is the blood test that we're looking at for kidney function, and we're wanting to see if that test is going up. And then the other thing that we look at is the serology tests. And these are most classically the C3, the C4, and the double-stranded DNA antibodies. And they go in different directions. So when the DNA antibodies are going up, that suggests your lupus is more active. And when the complement levels are going down, that suggests your lupus is more active. And the reason that when they're going down is a sign of activity is those are proteins that get used up in the inflammatory process. And so when they're not being used up as much and the inflammation's under better control, you'll see them improving. Moving on to how common is lupus nephritis? How often do we have to worry about it in our patients? It really varies a lot from location to location. In the first here, you can see the incidence of lupus varies between country and region. This is the number of cases per 100,000 people. And it can be anywhere from 5 to 9 per 100,000. If you look at how common once you have a diagnosis of lupus is, in general, it's about 40 to 50%, but it's higher in certain populations of lupus patients. And minorities, so African Americans, probably have the highest rate of lupus nephritis. This is one study called the Lumina study that was based out of Texas, Alabama, Puerto Rico. And in that group, 69% of African Americans with lupus had kidney involvement. It's less common in whites, about 30%, also higher in the Hispanic population. So Hispanic ethnicity has been associated with, in about 50 to 60% of Hispanics with lupus will also have kidney involvement. Question I get a lot when someone is newly diagnosed with lupus is, will I have kidney disease and how am I going to know when I'm going to get it? And unfortunately, we don't have the ability to tell you right now if you're going to get it or not. I'm hoping that with some of the omic projects that Dr. Wallace was describing, we will ultimately be able to better predict what the course of your lupus is going to be. So stay tuned for the next 10 years, I hope. What we can say, and this is pretty consistent with a lot of the studies, is that around the time of diagnosis is the highest percentage of when you're going to be diagnosed with kidney involvement. So this data comes from a really large, what we call inception cohort. So these are people who were diagnosed with lupus within the past 1 year to 1.5 years. And it was a study from multiple different countries and about 2,000 patients. And when they looked at it, about 80% of the people who got kidney involvement, and this was over a 13-year period, had it or at the time of diagnosis. And then you can see as you go a little further along, the first year, couple of years is when that curve tends to rise. So first 5 years is when we're going to want to be looking for it very aggressively. It starts to flatten out after that point, meaning there are less new cases of kidney involvement, but that's still not zero. So I can't tell you at this point that at 10 years, you're not going to get kidney involvement. It's much, much, much less likely, but still not zero yet. And then once we have kidney disease, one of the things we really worry about is the development of end-stage kidney disease, or your kidneys getting so much inflammation and scarring that they stop working and you need to go on dialysis. And how often does that happen? In that cohort that I just showed you of about 2,000 people, 10%, so 1 out of every 10 people who developed kidney disease went on to kidney failure. Dr. Petrie at Johns Hopkins has a long-standing lupus cohort, and at 20 years, 8.4% of her patients with kidney involvement had gone on to dialysis. Other studies, it's been as high as 22%. So there, probably somewhere between 1 in 10 to 1 in 5 people who get kidney inflammation, unfortunately, will not respond to therapy and need to start dialysis and consider transplant. This is a really busy slide, but I think it's very important data. This was published back in 2011, so now 14 years ago. And what this study is it looked at all people who were starting dialysis. So this is new starts of dialysis across the United States. And they pulled out people with lupus who were needing to start dialysis. And I have the red here highlighted is what I want to try and focus on. And this is on the left-hand side is the earlier years, the right-hand side is the later years. And it's really disappointing to me that I see an increase in the number of new lupus nephritis patients needing to go on dialysis over time. So even though we're getting more therapies, we're having more people need to go on dialysis. And this to me says we've got to really focus our efforts here, and there's a lot of room for us to improve our care in lupus nephritis. And the other thing too, these are 40-year-olds on average that are going on to dialysis. Why do we care so much about dialysis? People who go on dialysis have a lot of complications. It's quality of life issues, decreased lifespan. It's a tough situation that we really want to avoid. There's also about 80% of the people going on dialysis were female. This is a little lower percentage than what we see in the general population, which says men are at a little bit higher risk than women to go on to dialysis if they have kidney involvement. What it can't tell us is maybe these numbers are going up because there are more people being diagnosed with lupus during this time frame, and I'm hoping that that's the situation, but we don't know because this is only looking at dialysis patients. It's not looking at all lupus patients in general. The other things that were very interesting about this study is over time, there was a rise in the number of people aged 5 to 30 who were needing to start dialysis. So again, a population that we're not doing as well in. There was also the incidence of going on dialysis was rising in African Americans. And it was also worse in the Southeast US. So I think these are all populations that we need to focus our efforts on. There was a higher incidence of diabetes, hypertension, and obesity in people who were going on dialysis as well. So these are somewhat, as Dr. Wallace was talking about, some comorbidities or conditions that people also have that maybe if we do a little bit better job of treating those could also help treat their kidney disease a little more. Some of the factors when you look at big groups of lupus patients, if you're trying to figure out who do I need to worry about more, who's got an increased risk of having problems, they're people with abnormal renal function, so the creatinine that's a little bit high, more protein in their urine, so this is more than 2,600 milligrams in 24 hours, a low albumin, and these two kind of go together. If you're peeing out more protein, the albumin, which is the protein in your blood, goes down. It's kind of like a plumbing issue. High blood pressure. If you have that class 3 or class 4 on your kidney biopsy, if you've got scar tissue on your kidney biopsy, especially if there's scar tissue in something called the tubular interstitium, that's also an issue. If you have anemia, if your complement levels are low, if you have antiphospholipid antibodies, if you don't respond to treatment, and again, African American race and Hispanic ethnicity have been two factors that have been associated with having more severe disease and complications from lupus. This is Dr. Hahn's slide. For those of you who know Dr. Hahn, she is an amazing lupus clinician and really a leader in the field of lupus for decades. This is the natural history of lupus before we had a lot of treatment. And what you can see, I don't think I've got is this a highlighter? There we go. So these are people before we had treatments for lupus. If you got inflammation in your kidneys and were on low dose steroids, no one was alive at 2 years. So our drugs are working. We've made progress, and that's one of the things, because I don't want this to be all doom and gloom. Our drugs are working. We're not at this at all, but we have a lot of room for improvement. I wanted to include a couple of slides about what the standard of care had been prior to the development of the new guidelines. The backbones of our therapy had been cyclophosphamide for many, many years. So when I started my fellowship back in the 90s, this is really all that we were using to treat lupus kidney disease. And I think that there's really pretty good data about why it works. And one of the things I want to highlight out here, these are 5-year studies. And you really saw the difference starting 2 years and later. So it's very important as we're looking at lupus and lupus treatments that we get the long-term studies. I think a lot of our trials do not capture what happens later on. But you can see in this slide that after a couple of years, the people who got either oral cyclophosphamide or intravenous cyclophosphamide had a much, much lower risk of kidney failure. Only 10 to 20% went on to kidney failure, which is kind of the percentage that we're still seeing. But if you got azathioprine, which is also called Imuran, or just prednisone, your chances of going on to kidney failure were much higher in a 5-year period. And so it was really this study that led us to include, to have this be the standard of care. And then in the 90s, along comes Cellcept, which is also called mycophenolate mofetil, or mycophenolic acid is another preparation of it. And it was first used for kidney transplantation and other organ transplantations. And a lot of our drugs in lupus, we borrow from other diseases. And they got the bright idea that it's a very similar drug to azathioprine. And maybe if azathioprine was providing some benefit, this drug, which seemed to be more effective in transplant, would be more effective in lupus kidney disease. So that's sort of the backstory there. And Dr. Ginsler set up a trial. This was a labor of love for her, where she had about 70 patients in each group, and they were randomized to either CellCept or cyclophosphamide. And what you can see here is the complete response. Not great, 20%, but better than cyclophosphamide. Partial response, about the same. This is the combined, this orange bar is the combined complete response plus partial response, about 50% in the mycophenolate group and about 30% in the cyclophosphamide group. And then the blue is the non-responders. Because of the small sample sizes, these results were not statistically different. So what they could say is that CellCept or mycophenolate was at least as effective as cyclophosphamide was. This led to one of the largest trials at the time that had ever been done in lupus kidney disease, called the ALMS trial. And there are about 370 patients in this trial. And they randomized people in the beginning to cyclophosphamide through the vein or mycophenolic acid. And what they could see in this study is that it didn't work differently. We had about a 50% response rate with whatever drug you use. So if your cup is half full, they both worked. If your cup is half empty, we're only getting about 50% response rates. What was interesting in this is if you were, and it was mostly African Americans in this group, but non-Asian, non-Caucasian, that maybe the mycophenolic acid worked a little bit better. But because of these couple of studies, the initial approach to treating lupus kidney disease was putting people either on cyclophosphamide or mycophenolate mofetil. Now getting back to what these new guidelines are. I think we can see that there was a desire to get better outcomes other than 50% response rates, and we have some new approaches that looked like there was an improvement upon that strategy. Some of the basic recommendations with the new guidelines are that if you have a diagnosis of lupus, at least every 6 to 12 months, you should be getting a urine test done. If you have some of those risk factors that were associated with poor prognosis, probably should be getting them more frequently, in my opinion. If you start having changes that are suggestive of active inflammation in your kidney, and this can be protein in the urine of more than 500 milligrams in a 24-hour period. We often don't do 24-hour urine collections anymore. For any of you people who've had to do those before, they're not a lot of fun. We often are just going over the spot protein to creatinine ratios. And that's just the quantification that I was talking about. So if you have a new onset of protein in your urine, or if you're having increasing proteinuria or new red cells or white cells in your urine that are not from an infection, or you don't seem to be responding to therapy, then getting a kidney biopsy is recommended. The kidney biopsies are done, you're awake, you're lying on your stomach. They just give you local numbing medication, have you take a deep breath, and then they do the biopsy. If you have class 1 or class 2 on the kidney biopsy, then there really aren't any specific recommendations other than focusing on treating the other aspects of lupus that are active. If you have class 3 or class 4 or class 5, so these are the proliferative ones or the membranous ones or any combination of those, hydroxychloroquine, which is also called Plaquenil, is recommended that everyone be on that. It's also recommended to use a medication called an ACE inhibitor or an ARB, because this can help decrease the protein in the urine. There's also some data that's mostly out of people with diabetes that it may help decrease the scarring in the kidney as well. And a lot of our lupus medications, the immunosuppressants and the biologics, are pretty good at treating the inflammation. They're not as good as at preventing the scar tissue. So I do think using this with the idea that maybe we're decreasing the scarring that's happening is quite important. This is a change from the previous guidelines. The previous guidelines had recommended much higher doses of prednisone and pulses. The newer guidelines recommend using 250 milligrams up to 1,000 for 1 to 3 days with a new diagnosis to try and jumpstart and suppress the inflammation quicker. The reason for doing this is the other medications just don't build up in your system as quickly. So nothing works quite as fast as prednisone does, unfortunately. And then I think this is quite different. The recommendations, we used to put everyone on 60 milligrams a day of prednisone, give it at least a month, and then start tapering. Now the recommendations are using 0.5 milligram per kilogram a day up to 40 milligrams. So these ones, the maximum dose that you start at is 40 milligrams a day, and tapering to get the dose 5 milligrams a day or less by 6 months. And this is because, as Dr. Wallace was mentioning, as we had the opportunity to take care of lupus patients for longer, we're seeing the complications more and more of long-term steroids and not necessarily the benefits. And then another one of the changes I think that's really important to think about and highlight here is this is a long-term treatment. That when we start people on these therapies, it's going to be with the idea that you'll be getting treatment for at least 3 to 5 years. And the reason for this is we want people in a deep remission. Even when people we think are in remission and have gotten a kidney biopsy afterwards just to see, there's often still a little bit of inflammation going on. And we want to do everything that we can to prevent the development of scarring and damage and the need for dialysis. For people with class 3 and class 4 kidney involvement, in addition to the prednisone and the ACE inhibitors and ARBs and the hydroxychloroquine that was mentioned, the next choice is either using mycophenolate and belimumab or cyclophosphamide. Actually, sorry, take that back. It's using mycophenolate and belimumab or mycophenolate and a calcineurin inhibitor. And the most commonly used calcineurin inhibitors are voclosporin and tacrolimus. Cyclosporin is also a calcineurin inhibitor, has a little bit more side effects and a little harder to use, I think. So it's less commonly used, but is an option. So mycophenolate is recommended over cyclophosphamide in these guidelines. If there are reasons why you might want to use cyclophosphamide first, another option in these guidelines is second-line therapy is to use cyclophosphamide, but to use it in combination with belimumab, and then do this for 3 to 6 months and use the combination of mycophenolate and belimumab as more the maintenance therapy. Why do we want to do more medications up front? It's because the newer trials have shown that when you do what they're calling multi-target therapy, so trying to target different ways the immune system causes problems in lupus, it's a more effective treatment strategy. So this was the trial called the BLISS lupus nephritis trial that compared people with lupus kidney disease who were given Cellcept or mycophenolate compared with mycophenolate plus belimumab. And it takes a while for you to see the difference. So these aren't effects that you can see right away. And I think that's important to know, that don't give up too soon. It's here at about 6 months where you start to see that the people who got the combination therapy are having a better response than the people who were just on mycophenolate alone. And this is response. This top one includes both partial and complete. And this bottom one is complete response only. And again, it starts to separate where you see a significant difference for complete response at 32 weeks. So you have to be patience, which is not always easy for the patient or the physician. And I think one of the other things that's really important to see here is this is a durable response, meaning it's lasting and you're continuing to see the benefit. Because really, we don't want to know what's happening at 1 year. We want to know how you're going to be doing 5 years, 6 years. And a lot of the studies are just not long enough, in my opinion. This is 2 years. This is long for a lupus nephritis trial. And you can see that the benefits that you get with belimumab added on to CellCept are persistent. So I think really important. I think the downside is when you look at the numbers, they're about 55%. So we still are having a little over 40% of people in these trials without a complete or partial response. As we look through these trials, the numbers are going to look different for response rates. And that's one of the problems with lupus trials, is everyone defines response a little bit differently. And that's, I think, made comparison from one study to another hard. So take that with a grain of salt as you're looking at the differences in response rates. So that's one multi-target approach. So the mycophenolate and the belimumab, which is targeting B cell activation. These are a couple studies looking at mycophenolate and the calcineurin inhibitors, which focus more on a different type of white blood cell called T lymphocytes. And this one was done, published back about 10 years ago now. And really interesting study that was done in Asia, compared IV cyclophosphamide, and this was using what they called the NIH regimen, so pretty good aggressive dosing of cyclophosphamide, compared to the MT, which stands for multi-target therapy, which was prednisone, mycophenolate, and tacrolimus. And you can see with the calcineurin inhibitors, you get a little bit quicker response rate. And that's in part because a lot of the response rates are based on how much protein is in the urine. And the mechanism of action for these calcineurin inhibitors is that it really decreases the glomerular filtration rate a little bit and will decrease the protein more so than with other approaches. But nonetheless, this is only 24 weeks. So this is 6-month study, but really significant differences in the response rates at 6 months. This is a longer study published more recently in 2021, looking at voclosporin in combination with mycophenolate versus mycophenolate alone. And again, you see nice responses earlier on than what we were seeing in the belimumab studies. At week 24, you can see a difference. The blue here is the combination group, and the pinkish reddish group is the mycophenolate only group. And these are people with complete response, and these are people with complete and partial response. And again, definitions are a little bit different, but a 70% complete and partial response. So much better, still not 100%, which is what we're looking for. So you can see that when you combine these medications, you get better response rates. These trials were designed to start both medications at the same time. And I think that if we're trying to replicate what was done in the trials, we need to start 2 medications at the same time. And I think that's sometimes hard. You have a new diagnosis and someone's telling you to take all these different medications at once, but it's important. Moving on to class 5 disease, which is membranous, little bit different entity. It's not as many white blood cells there. You don't see as much of the lower complement levels or the DNA antibodies, although you can. Some people just don't have that. People can have massive amounts of protein in their urine with this condition. 10, 20 grams of protein, bad swelling in the legs, really foamy urine. And the severity of the disease in this condition often relates to how much protein is there. So if you have less than a gram of protein in your urine, it's not felt to be as severe, and you probably don't need as much medication. And you can get away, or we try to get away with steroids in just one of the drugs that we've been talking about, either the mycophenolate, the azathioprine, or one of the calcineurin inhibitors, which is the tacrolimus or the voclosporin typically. If you have more protein in your urine, then you're going to want to treat it more aggressively with this multi-target therapy. And the calcineurin inhibitors, as we were seeing, where with the mechanism of action, it decreases the protein quicker, are going to be your first choice as opposed to thinking about belimumab. I think that's probably enough. If you have kidney involvement and you try these approaches and things aren't getting better, what's recommended is if you only started with mycophenolate or cyclophosphamide, add that second agent and do multi-target therapy in addition to the prednisone that you're on. If you've already started and say you've been on mycophenolate and a calcineurin inhibitor, and at 6 months you're not seeing the progress that you want to be at, switch to the other one. So switch the calcineurin inhibitor to belimumab or vice versa. Or think about adding an anti-CD20 agent, and I'll show you the ones classically that's been used as rituximab, but obinutuzumab is the new kid on the block and probably what we should be reaching for. The other possible, and if you've already done this and then it's still not working, one of the things that you can try doing is using a combination of all of them. So using the mycophenolate, belimumab, and a calcineurin inhibitor, or think about participating in an investigational therapy. And I think that it's really important to think about some of these investigational therapies because as you look at the studies, our response rates are 50 to 70%, and we really want to get to 100% response rate and prevent the development of end-stage renal disease. When you have lupus kidney involvement, the guidelines recommend monitoring labs at least every 3 months. I think initially, as you're starting treatment, it should be at least every month that you should be getting blood work done, my editorial. And if you're in remission, at least every 3 to 6 months. And like Dr. Wallace said, if anyone wants my slides, they're available for everyone. This is, if you want everything that I just said in one image, this is it. Now, here's some of the exciting stuff. These are the new kids on the block, obinutuzumab. This is a study that was published in the New England Journal in 2025. Very exciting. Obinutuzumab is another anti-CD20 molecule, but it's a little bit stronger than rituximab and gets rid of the B lymphocytes a little bit more effectively. Oopsie. So this is, everyone is like all the other studies, all the patients are on mycophenolate, and the randomization is either you get obinutuzumab or placebo. So the patients who got obinutuzumab had a response rate of 46% compared to 33%. So really, I think pretty nice data. And then this is just a little taste to set up our next speaker. This is CAR T therapy, and this has been in the news a lot. This was published in the New England Journal, which is our main medical journal last year. And this is the follow-up study. There had been one a couple years before that. This is 8 patients with lupus. So I think there's small numbers. It's not randomized. Take it with a grain of salt, but they're really impressive numbers. So CAR T therapy, CD19 CAR T therapy is the principle similar to rituximab or obinutuzumab. You really want to get rid of the B lymphocytes. This is just really, really effective at getting rid of the B lymphocytes, and maybe a little bit more effective at getting, the thought is it maybe a little bit more effective at getting rid of tissue level B lymphocytes. So are we going to be a little bit better at getting rid of the B lymphocytes in the kidneys or other organs? I think we need to see that, but that's one of the ideas. These are people who got CAR T cell therapy, and with it, they also get other immunosuppressive therapy. So you have to wipe out the immune system, as we'll hear. So there's other drugs that could be contributing to the response. But these are people who had been on, who were not responding to the medications that I had described earlier. And this is their lupus disease activity score called the SLEDAI-2K. And you can see it goes down to 0. And this is 2-year data. This is the DNA antibodies. They also become negative. This is the protein in the urine. And you can see some of the patients had up to 7,000 plus milligrams of protein. They really pretty much resolve. One patient had a blip, but went back into remission as well in the 2-year data. And this is also complement levels and normalization of the complement levels. So really, really exciting data about where we are going or potentially going in the field. And then I also wanted to leave with a couple of optimistic thoughts. When I started my fellowship, so this is prior to starting fellowship in 1986, there were no drugs that were in development for lupus. In 1996, we had 3. In 2006, we had 13. And then last year I went through and counted up, and I was trying to not double count because some of the drugs are being used for a couple of different trials. So this was just individual drugs that there were over 35. So I think that we are really in a very exciting time period for lupus where we are going to be getting new therapies. And I'm very much looking forward to seeing what the next decade holds. And Dr. Wallace had kind of mentioned these as well. The CAR T therapy, there's another cellular therapy it's called natural killer cell therapy in combination with the rituximabs or the obinutuzumabs to try and enhance the B cell cytotoxicity or killing. There's a study looking at anti-CD38, which is on a different type of white blood cell. Anifrolumab is in phase 3 studies looking at, and this is for nephritis. It's already FDA approved for non-nephritis indications. They had an earlier study where it looked promising at a higher dose for anifrolumab. So this new study is using that higher dose in it. So I'm optimistic for this. This is a medication that also blocks B cell activity. This is a complement factor. And this is one of the neat things. It's a biologic therapy that blocks 2 different parts of the immune system. So lots of different approaches right now, different targets, and I think we're in for some excitement. And I think I saved some time for some questions.
Thank you, Dr. Grossman. So what we're going to do is we have a lot of questions from the live streaming audience. So we're going to take one in the room, one from online. So if anybody has a question, please raise your hand. We'll hand you the mic. Anybody in the room? All right, we're going online. Brianna?
Great. Can you guys hear me?
Yep.
Okay. Dr. Grossman, the first question is IBS common with SLE and or lupus nephritis?
IBS?
Yeah, irritable bowel
Irritable bowel
syndrome.
syndrome. IBS is common in general. I don't know if I've seen any data that it's more common in lupus than in the general population. Mechanistically, I could see why there might be some reasons for that. I think also it's a little bit hard. A lot of our medications cause a lot of stomach symptoms.
Yeah.
So I think if you're having symptoms of IBS, it's really important to sit down with your treating physician and try and sort out, is it IBS or could some of the medications that you're on be contributing to the symptoms?
Definitely. Our next question is, are there home urine test strips that you can do to see if there's a kidney problem rather than just when you go to the doctor? Or how do you watch your kidneys if I only see my doctor twice a year?
Yeah. So yeah, there are home strips that you can do. They're not as accurate as the protein to creatinine ratio or the albumin to creatinine ratio. So they can be used as a screening test. If you have an abnormality on the dip, don't lose sleep over it. Go in to get the more accurate testing done would be my greatest recommendation. Who should be using those strips? I think that they're probably best used in people who are at the highest risk for developing kidney disease. So who are those people? Probably people within the first 5 years of disease, people who have high levels of DNA antibodies, low levels of complement, other signs of active lupus like rashes, arthritis, fevers that aren't controlled. SSA antibodies can also be a risk factor for a higher likelihood of developing lupus kidney disease. So those are people who probably would have the biggest benefit from doing the home strips, in my opinion.
Okay, perfect. This question's a little bit technical, but from biopsy, if someone is NEL1 positive, has been diagnosed with MN, and immunofluorescence is full house except for C1q, is this early lupus nephritis?
There is this category of membranoproliferative changes on a kidney biopsy that are suspicious for early lupus kidney disease, but they don't meet all of the other classification criteria. I think it's been more recently described the past 5-6 years. So I think it's possible. I think many people would often give a trial of treatment for lupus kidney disease in that situation. But I think it's also an area that we really need to learn more about.
Okay. Next question. I saw online that COVID can potentially cause kidney scarring or affect kidney function after infection. Is this true? Have you seen this in your practice? And if yes, should we have our urine checked if we get COVID again?
Maureen is sitting in the audience. We've had this conversation multiple times.
Wow.
I do infections are a known trigger for lupus. COVID has definitely been described as a trigger for lupus flares. Anecdotally, we always say we can tell when there's been a flare, a surge in COVID because we see more lupus patients getting admitted to the hospital.
Wow.
So I do think the two can go together. I think making sure if you're having more symptoms to make sure you're getting into your physician to be evaluated. And it's probably not a bad idea if you've had a significant COVID infection to go in and get checked up.
Okay. Thank you. Our next question is it true that you shouldn't drink dark soda because of high phosphorus for lupus patients with kidney problems?
That's probably a better question for a renal dietitian. I
Okay.
do think the soda does have a higher phosphorus content. I think just in general, the sodas they don't have a ton of nutritional value.
Okay.
And if we're thinking about the gut microbiome, highly processed foods seem to have a negative effect on the gut microbiome, meaning the highly processed foods like sodas, cookies, processed meats can look like they can lead to more inflammatory bacteria in your gut, which we think is maybe contributing to more activity for lupus. So just from a general lupus health standpoint, avoiding soda, because it's a highly processed food, I think would be a good recommendation.
Okay. And then we'll just do one more, because got to keep moving. But I saw online that GLP-1s may possibly help with lupus nephritis. Could a GLP-1 medication be taken with these new medications recommended for lupus nephritis treatment, like the steroid and calcineurin inhibitor?
Oh my goodness, you ask an amazing question. I do think that there's a lot of interest. There's case studies that look like it's effective. Dr. Wallace was talking earlier that it may have some beneficial effects on the immune system.
Wow.
When we look at Karen Kostenbader's dialysis data, there was a higher incidence of diabetes and obesity in people who went on to kidney failure. So could we just even be decreasing the risk of kidney failure because we're treating those comorbid conditions with the GLP-1 agonists? There are so many potential benefits, but I think it needs to be studied better. And we, as rheumatologists, I can tell you right now, they are not giving lupus insurance companies are not letting us use lupus as a reason to get these medications approved. So I'm taking advantage of, in UCLA, we have clinical nutrition. So I'm sending a lot of my patients to clinical nutrition when I want to see if they can help us get a patient on this type of medication. And but if any of you have been out trying to get the medications, they're hard to come by.
Yeah.
Still,
Thank you so
unfortunately, one day.
Yeah, thank you so much for explaining that. And thank you so much, Dr. Grossman. This was really awesome.
Okay, it is my pleasure to introduce Dr. Andrew BitMansour. He is with Fate Therapeutics. And again, they have a table outside. They're recruiting for a trial. So please feel free to go talk to them when you're having lunch. Thank you.
Thank you. I would like to first thank the organizers for inviting us to discuss our clinical trial studies at Fate Therapeutics. And thank you all for taking the time on a Saturday to come to this conference, which has been really educational so far. And I'm very fortunate to follow Drs. Wallace and Grossman for setting up a really nice introduction and description of lupus and lupus nephritis pathophysiology. So it makes my job really easy. As you saw, there's a lot of exciting approved and upcoming therapies for the treatment of lupus. What I'm going to concentrate on is what we're working at Fate Therapeutics, which is CAR T therapy, which is a really hot topic. I'm sure you all have heard about it. There we go. So that's the title. We have developed off-the-shelf CAR T therapy for lupus. But let's first examine what's the rationale for CAR T therapy. As you saw earlier, lupus is a very complex and heterogeneous disease, and there's a lot of factors involved in the development, the pathophysiology, and the progression of lupus. There's the genetic component, which you heard earlier. There's multiple other factors, such as the environmental factors, dysregulation of the hormones, and all of this combined with the ineffective system with the immune cells that can contribute to the development and progression of lupus. One of the components of the immune system are the B cells, which you heard earlier. B cells produce antibodies, which are specific proteins that each have specific targets on different cells. As you know, lupus patients, when they're diagnosed, they test for levels of different types of antibodies, such as double-stranded DNA, Smith, and SSA. So when those levels are high, that's indicative, that's a prognostic factor of lupus. And that means that the B cells are acting irregularly, they're not acting normally, and they contribute to the development of lupus. So then the B cells are a good target for therapeutics to see if we can remove or reduce the numbers of these abnormal B cells and hopefully help with alleviation of the disease in lupus. Before I get into CAR T therapy for lupus, they were actually examined initially in the setting of cancer. Actually, if you see on the left-hand side, there's actually 2 approved CAR T therapies for B cell cancers. And so they had the same approach. They saw that there's B cell driven cancers, and therefore using CAR T therapies, they were able to get really good responses. So a few years ago, an astute observation was made by an investigator in Germany, as mentioned earlier by Dr. Grossman. Dr. Georg Schett thought to himself, well, if cancers, especially B-cell driven cancers, can be treated effectively by CAR T cells, we know that lupus, one of the factors is B cells. So can we use the same rationale, the same approach in treating lupus by using these CAR T cells? And some of these figures are actually repeats. And he treated his first lupus patient, and I think that was around 5 years ago, with lupus, with 1 dose of CAR T cells. She did terrific. She responded very early and very well, and she's in remission, and she's been in remission ever since. As a follow-up to that early study, he treated more patients in lupus, but also other autoimmune diseases that are thought to be known to be driven by abnormal B cells. And here's the results, as you saw also earlier, that the responses were terrific and that patients responded rapidly and continued to be doing well. So it seemed to be, at least up to now, a really durable response. So what are CAR T cells? I made this little slide to break down. We have different components of our immune system. As you heard earlier, we have T cells. Those are specialized cells with receptors on them, as indicated by that yellow Y-type shape. And when they pair up with their target cell, they get activated and they can kill the target cells by releasing these toxic molecules. So the effectiveness of the B cells is by finding their target cells and killing them through these particular molecules. We also have B cells that we know are specialized in making these proteins antibodies, which have very specific targets. We've heard of anti-CD19, CD20. Those are markers on cells that are associated with the specific type of cells. And there's antibodies specific to that can bind only to CD19 or only to CD20. So it's a very targeted specific system. So the T and B cells, of course, with other immune cells, combine to make the components of our immune system. So the rationale for developing CAR T cells is, why not take one of the best aspects of a B cell, which is the antibody, combine it with a potent T cell and create one supercell where we have a CAR T cell that has been equipped with an antibody. So therefore the antibody can find its target cell and therefore allow the T cell to kill it. So that's the basis of the CAR T cell technology. As I mentioned earlier with the study in Germany, the patient and other subsequent patients were treated with what we call autologous CAR T cells. That means her cells were initially removed from her. They were prepared, CAR T cells were made, and then they were reintroduced back into this into the patient. So that's called autologous CAR T cell therapy. So the way it's done is the patient is screened, their white blood cells are collected, the T cells are isolated, the CAR T cells are generated in the test tube in the lab. Then they're expanded to give sufficient numbers to be functional in the patient, and they're reinfused back into the system. So that's the autologous CAR T cell generation. As you can imagine, it takes a lot of time and it takes a lot of money to develop this. And there's a lot of complications associated with development of these autologous CAR T cells. There's another group of CAR T cells, and those are called allogeneic or off-the-shelf CAR T cells, where the CAR T cells are already pre-made. So when the patient is screened, then they can be immediately following the lymphodepletion, which occurs in both autologous and off-the-shelf CAR T cells. Following that lymphodepletion, patients are given the CAR T cells and they're good to go. So we think there's benefits to that in that the patient doesn't have to undergo leukapheresis, isolating their cells and making the cells in the lab. There's no processing involved, and the cells are available. So once a patient is screened, then they can be sent the CAR T cells and be infused pretty quickly. And so how is the off-the-shelf CAR T cell made? We started by isolating T cells from a healthy female donor, and we turned them back into a stem cell, which is a type of a cell that makes it more malleable and more permissible to introduce the CAR T cell receptor onto the cell. Following that process, we turn the cells back into a T cell so they can be functional killers. And following the lymphodepletion and infusion, CAR T cells can find their target abnormal B cells in the system and kill them. So we've summarized all that process, and the cells are pre-made and ready to be infused. So what does our study entail? Patient that is screened will undergo the pre-treatment as discussed earlier. And this is in consultation with the rheumatologist and the cell therapist into what type of preconditioning the patient would benefit the patient most. They can either come in on their background therapy that have stable doses, such as mycophenolate, methotrexate, or azathioprine, or they can go a more traditional preconditioning, which is either cyclophosphamide or bendamustine. And this is a decision made between the patients and the doctor. And following that pretreatment, they get 1 dose of CAR T cells, and they're hospitalized for 3 days just to make sure everything is done well and look for any safety factors that may be associated with the rapid expansion of the CAR T cells in the system. And then after that, there's a standard follow-up, which goes for weekly for about a month, and then transitions to 1 month, and then 3 months, and then over a long period of time. So what type of a patient can be registered in our paid clinical trial? So a patient that comes in that has either severe active lupus involving the kidneys, so lupus nephritis, lungs, hearts, eyes, muscle, blood, or blood vessels. We do not include brain as per mandated by the FDA. So no CNS lupus is included in the trial. The patients are usually have been treated with multiple pre-treatments, and they have not demonstrated any efficacy by those treatments, and that's why they come to our trials to see something more beneficial, hopefully. And then one of the exclusion factors is not being pregnant or breastfeeding and willing to use birth control, because we don't know the safety of CAR T cells for a patient and their fetus. So to wrap it up, what are we doing differently at Fate? We have developed, I hope I have impressed on you that we've developed uniform cells that are all functional fighter T cells that are CAR T cells that can be really effective and ready to be infused in the patient. So therefore, we don't require and no leukapheresis is necessary, no waiting for cells to be produced. Cells are ready to be shipped and infused. And you don't have to stop the medications taking weeks before, so you can come and enter the trial almost immediately. And I think very importantly, the doctor and patient decide between pre-meds and what's best suited for that individual particular patient. So that's what I have for you, and thank you for your attention.
Thank you so much. We're going to break for lunch. Anybody that's here that has a question for Fate, please visit them. Anybody that's live streaming, please add your comments and we will send them to Fate. We'll make sure that everybody's questions get to the right doctor or the right speaker. Okay, so we'll break for lunch. Thank you so much. Yes. It's probably not. I like this. I think the x-axis. I had a deaf friend that would just tell people, tell your wife this. It's a lot for science. Ugly.
It's amazing.
Yeah, so it was interesting. Please make sure you eat.
Yes.
Somebody lunch. One thing I know.
Well done.
Thank you.
Well done.
Hey, I know.
Don't ruin the instruments.
I know.
Careful.
I know.
Let's
You gotta be careful.
You got ready?
Like, yes, yes.
Let's do that.
Touch that in.
It's freezing. Yeah, it's freezing over there.
Is it? Really?
I had to step out. Every chance I knew. You had laughed and try to put it. Yeah, because it was so cool. We were having.
And now that you.
Yes. Yes. It's, confusing. It's a part of fear. Second nature for you. It's just.
I realized during the open, I was like shifting my feet and my foot was on your. Like I've been shifting here on my shoulders, but not. And
Yeah,
yeah,
I should.
oh yeah. But it wasn't
I don't
that.
think so.
It was for a purpose. You know, the syntactic.
Yes.
But I probably need to incorporate that a little bit more, just remember don't write.
I'm trying to visual. That's all. Yeah. Translate.
Yeah. Sorry.
Hi, everybody. Thank you so much for coming back after lunch. We hope everybody live streaming had a lunch break and everybody in here. It is my pleasure to welcome another member of our medical advisory board and a rheumatologist here at UCLA, Dr. Maureen McMahon.
Thank you very much. Hopefully we'll keep everybody awake after our nice lunches that we just had. So I'll kind of preface this by telling you kind of how this became an area of interest for me. When I was a fellow here at UCLA, I was on one of the inpatient services for my first month, and we had a patient who was 28 years old. And this patient had had lupus since she was a child, but it was actually doing really very well. So she'd been trying to get back into shape and start exercising, but it found that when she was exercising, she actually started having chest pain. So she first went to urgent care and they said, oh, well, you probably pulled a muscle or something, and they gave her some ibuprofen. And then it continued happening, and she went back this time to the emergency room because she was having even more pain. And at that point, they said, well, maybe you're having a flare of your lupus and it's pericarditis. And they gave her a steroid dose pack. And then finally, by the time I met her, she had actually come in and had had a heart attack. And I think that that was really a huge wake-up call for me about the increased risk that we see in patients with lupus of heart disease. And so that's been an area of my interest, both clinically and from a research perspective ever since that day, really. So here's a little bit of good news. We know that when you compare, what happened to lupus patients in the 50s through the early 80s, you could see that if you look overall at mortality in lupus, lupus patients were dying much earlier than patients of the same age in the general population. And fortunately, as our treatments have gotten better, as we've gotten better at diagnosing patients earlier, that mortality really has improved quite a bit. However, we do know that when patients with lupus do die, early on, right after they're diagnosed, we'll see one peak of mortality, and that's usually from very active lupus or from infections. But we know from data from a group in Toronto that there's another peak of death in patients with lupus, starting about 8 years after patients have had a lupus diagnosis. And we do still see infections as a big cause, but the other big cause is heart disease. And in fact, when you look overall at patients with lupus, they can have about a 10 times increased risk compared to age-matched patients in the general population who don't have lupus of having a heart attack, or of dying from dying from heart disease. But I think that the thing that's most striking, and this kind of reminded me of my patient, is that there's a group of patients, usually when we think of young women, we don't think of young women as particularly being at risk for heart disease. And I think that's what happened to my patient. Nobody was thinking about it as a risk factor for her. But in fact, when you look at patients who are 35 to 44 years old, they have a 50 times increased risk of having a heart attack compared to patients who don't have lupus. So again, I think it's very important to recognize this. It's a message we've really been trying to get out, not only to rheumatologists, but also to primary care providers and cardiologists and ER doctors, just so that we all recognize that this is something we have to think about. And it's important as patients also to make sure you're sharing any symptoms that you have with your doctor. So we know, of course, there are some things that lupus patients have risk factors for. Lupus patients who have antiphospholipid antibodies have a higher risk of having blood clots, et cetera. But we actually do see an increased rate of artery thickening or plaques in lupus patients. And you can kind of see that that happens at every decade of life that was looked at in this study. So even, again, like very young patients, if you look in the first column over to the left, you can still see that the risk of having early signs of atherosclerosis were present even at a much earlier age than we would expect to see. So why does this happen? I think there have been a lot of theories, and of course we know that many of the treatments that we use in lupus, like steroids, for example, can increase blood pressure, can increase risk of diabetes. Other patients, it's hard to have to do as much exercise when you're having lupus flares, et cetera. So we know that a lot of these, what we call traditional cardiac risk factors, are certainly at play in patients who have lupus. So you can see here kind of across the board, all of the different kinds of what we call traditional cardiac risk factors. So high blood pressure, smoking, increased cholesterol, diabetes, having a sedentary lifestyle, and even a family history of heart disease. Those are all seen in patients who have lupus. So certainly these are playing a factor as well. And in fact, when you look overall at patients who are more likely to have that artery thickening, again, if you have high blood pressure, if you have diabetes, and for males, there's still an increased risk, just as we see in the general population. But we also know that there's things about lupus disease activity itself that can actually cause some of the risk factors as well. So in particular, when we think about cholesterol levels, here, if you compare in the green patients who have active lupus compared to patients whose lupus is inactive, compared to patients who don't have any lupus at all, you can see that you have some of the risky lipid factors. So, for instance, patients with active lupus are more likely to have higher total cholesterol, higher LDL levels, higher triglyceride levels, and low levels of what we think about as the good cholesterol or HDL. So again, even lupus itself is contributing to some of these traditional risk factors. And as I mentioned, we also know that steroids can be a big player in this as well. So steroid therapy itself can contribute to higher cholesterol, higher triglyceride levels, higher LDL levels, more likelihood of having diabetes, and increasing risk of weight gain. So again, just another reason why we're all trying to minimize steroids as much as we can. But interestingly, when we think about lupus, of course, we think about inflammation. And I think there's some indirect evidence to suggest that patients with lupus do have an increased risk of heart disease because of inflammation. So this was a study that looked at patients who had thickening or plaque of their arteries. And one of the things that I think was surprising to all of us was that even though we think of some of our medications like cyclophosphamide or Cytoxan or prednisone or even Plaquenil, we think about the side effects associated with those, but we also think about the inflammation and the control of inflammation. And so in this study, they found that patients were more likely to have thickening of their arteries if they were not taking some of these medications like cyclophosphamide, and less use of things like prednisone and hydroxychloroquine. Patients were also more likely to have thickening. So again, I think as we go along, we want to control any risk factors that we can, but it's also important to think about controlling inflammation. And so here again, just looking at other studies that have looked at children. And now again, when we're thinking about people that we think of at risk for heart disease, we don't really even start thinking about this in the general population when you're talking about kids or your average healthy kids. But we, again, do see increases in artery plaque in patients who are children who have lupus as well. And here, again, you can see some of that was associated with really high doses of prednisone, but patients who had had very little prednisone, and presumably the flip of that is that they'd had more inflammation, were also more likely to have increase in thickening. So again, I think, when we, think about all these traditional risk factors, again, I think that they're very important and they're some of the things that we know how to control. But it's not the whole story in lupus. So this was a study that, compared patients in Canada who had lupus to patients from the Framingham risk study, which you might have heard about if you follow anything in the cardiology literature. And that's just a long-term study that looks at a bunch of patients in the town of Framingham and studies what happens to their heart disease risks over time. And anyway, when they compared those lupus patients to patients from the Framingham study and matched them all up on whether they had any high cholesterol or hypertension or diabetes, or whether they were smokers or not, all those traditional risk factors, patients with lupus still had a 10 times increased risk of having a heart attack and a 17-fold increased risk of dying from heart disease, as well as an 8-fold increased risk for stroke. So again, there's something about lupus itself, and we think of it as being inflammation in lupus that is really contributing to this risk above and beyond what we have with the traditional risk factors. Now, one of the things we haven't really mentioned, but again, thinking about lupus inflammation, is kidney disease. And so when you look at patients who have had any history of kidney disease in the past, there again is an increased risk of having artery thickening compared to patients with lupus who had never had any kidney disease. So again, thinking about my patient, the 28-year-old, she had had kidney disease when she was younger. And even though it was under control now, it had taken a toll and likely done some damage to her arteries and caused thickening of the arteries. So one of the things that we have looked at in our group, and this was something that came out of discussions with cardiologists here at UCLA based on that young patient, was again looking for things that might be different in lupus patients. And one of the things that we found here is that sometimes because of inflammation, patients always don't have the same kind of function of their lipids that we'd expect to see. So we always think about the HDL cholesterol as being the good cholesterol. But what we found is that in lupus patients, there's some changes caused by inflammation that cause it to actually cause more thickening of the arteries and more inflammation. So we're trying to find things like this, markers that we can look for to see if we can identify specific risks in patients with lupus, and also see if there are things that we can do to correct those in the future. So I know some of you have participated in some of our studies, and we'll hopefully have some more to come in the future. So what can lupus patients do to decrease their risk of heart disease? I think, it would be great if I could stand up here and tell you, we found the magic bullet, we found, something specific for lupus that we can do to change risk for heart disease. But right now, really, I think our best approach and what's recommended by the rheumatology guidelines is to do what we can to minimize some of those traditional risk factors. So for instance, without going on any additional medications, there are things that you can do to decrease some of your risk of having abnormal cholesterol levels, for instance. So anything that you can do to decrease saturated fat and decrease cholesterol can be helpful. Exercise, and we'll talk a little bit more about it, is always helpful for most everything. Weight control can be helpful. And of course, if you're smoking at all, stopping smoking can be one of the biggest things that you can do to help decrease your risk of heart disease. So exercise, I know when I look at my patients, or when I tell my patients they should be exercising, they look at me like, you have no idea how hard that is to actually do. But I do really appreciate that it can be really difficult when you're feeling terrible, when you're hurting already. I know sometimes even exercising can make you feel a little worse at first. But I think it's important to remember that when we're thinking about exercise, it again doesn't have to be, going out and running 10 miles. It really, can include things like walking or gardening or things that you enjoy, but just doing it for, regularly, so that you're sure that you're actually getting some of that exercise in and having it be part of your lifestyle plan. And in fact, when we looked at patients who had that inflammatory HDL that I was talking about, we found that patients were much more likely to have that inflammatory HDL if they had low levels of exercise compared to those patients who were getting a lot of exercise. So again, that's one, non-pill thing that you can do to try to decrease some of your risk. And again, I bring this up, it's a lot of math to calculate how many METs of exercise you're supposed to get. And I don't expect anyone to memorize this or really, go in depth with this. But really just the point is that, again, it can be anything that you love to do. Any kind of form of exercise can be important. So for instance, I have a patient who loves ice skating. I would probably break my neck if I tried, but she loves it. So that's something that she is motivated to go and do. And so again, just finding that thing that will inspire you to actually go and continue, I think, can be really helpful. So blood pressure is, of course, another thing that is something that we can control. And of course, there are some things that you can do on your own if you're kind of in that borderline range. Minimizing salt intake can be helpful for many patients. There's definitely patients who are very salt sensitive, and so paying attention to that can be helpful. If your blood pressure is anywhere on the border, it can be helpful to have a blood pressure cuff at home. So, sometimes your blood pressure goes up a little bit when you come to the doctor's office, but if you have a number of readings at home, after you've been sitting down for about 10 to 15 minutes and relaxing, that's the time to check your blood pressure, okay? Because, running into the office after trying to find a parking spot and, dealing with traffic getting there, it's probably not the best reflection of what your blood pressure is doing normally. So a log can be really helpful. And so I mentioned the target blood pressure. So this has kind of come down over time to a range now of a target of less than 130 over 80. And that's what we call stage 1 hypertension. So above 130 over 80, and between 140 over 90 would be stage 1. And so that's a relatively new target that we have. We used to kind of allow blood pressures a little bit higher, but you can see from this data, these are people who have overall survival from having, having no heart attack, no stroke, and no death from heart disease. And you can see that patients who had the lowest blood pressure target actually did much better, even than those patients who just had a little bit higher in that 130 to 140 over 80 to 90 range. So that's why we have that recommendation of trying to make sure your blood pressure is in that lower range. And so what about statins? Again, I know that, it's hard to think about being on additional medications when you're already on so many. But we really do, not only in the general population, but even in patients with lupus and other rheumatic diseases, have an accumulating body of evidence that being on a statin and lowering cholesterol levels can be really helpful. So this is a really large study that was done looking at large patient database. And you can see when you look at patients who were on statins over time, and this included lupus patients and RA patients, compared to those who never started statins, the patients who were on statins had decreased mortality overall over time. So again, that kind of goes along with what we know from the general population about the beneficial effects of statins. So how do you decide if you should be on a statin, or how does your doctor help you decide if and when you should be on a statin? So in the general population, we'll use these things called risk calculators, and we can do the same thing for lupus patients as well. And what these risk calculators will do, there's a number of different ones that doctors will use, but they'll plug in some data about you, things like your age, your cholesterol levels, your blood pressure levels, whether or not you're a smoker, whether or not you have a family history of heart disease. And that can be used to determine your overall 10-year risk of having a heart attack. Now, when you use that kind of a basic calculator for people in the general population, it's a really pretty good predictor. But what we found when we've looked at that in lupus patients, and again, I think this is probably driven in large part by the age factor, because we know that we can see events happen at much younger ages, but also, taking into account things like inflammation. These calculators really don't do a great job of picking out who's going to end up having problems with their heart in our lupus population. So there's a lot of work right now trying to figure out ways that we can be a little bit more accurate with this and help to identify patients a little better. So this is a calculator. It's called the Q-Risk3 calculator. You could actually go online and find it. It was developed in England. But it takes into account a lot more things, including, whether or not you've had a rheumatic disease, including lupus or rheumatoid arthritis. It takes some other medications and factors into account as well. And so you get a little bit better at predicting in lupus patients than you do if you use some of those traditional risk factor models. So again, these are things that we're working on right now as a field, trying to find maybe some more lupus-specific markers like the HDL I was talking about, to see if we can really get this even better so that we really know who to predict might be at highest risk so that we can help prevent any further incidents in patients. So a few words about hydroxychloroquine. Hydroxychloroquine, it seems, it's one of the older medications that we have available for lupus. It's been around forever, but we keep learning more and more about it, and learning about new ways that it can actually be very protective for patients. So there have been some data overall. We know that if you look at all kinds of damage, including heart disease and blood clots and strokes, we know that patients who are taking hydroxychloroquine were nearly half as likely to have increased damage from their lupus compared to patients who weren't taking the drug. And so that's one of the reasons why, if you don't have any eye problems, if you don't have any other allergies or contraindications to hydroxychloroquine, it's why we're usually recommending that patients stay on it for a long time. And we've gotten a little bit more information about hydroxychloroquine. We found that it actually also seems to decrease the risk of having blood clots. And of course, blood clots can also contribute to risk for cardiovascular events. So we think there's some cardioprotective effects of hydroxychloroquine as well. And we also know that patients who were on hydroxychloroquine were less likely to have that plaque development, the earliest signs of heart disease, than patients who weren't taking it. So some of the reasons for that, again, I mentioned the decreased risk of blood clots on hydroxychloroquine. There also are some studies that show that hydroxychloroquine can have some beneficial effects on overall cholesterol profiles, especially in patients who are on prednisone. So, of course, we always like to minimize prednisone if we can, but for patients who are on it, and are also on hydroxychloroquine, they're less likely to have abnormal lipid profiles. They're more likely to have lower total cholesterol levels, for example, compared to patients who aren't taking hydroxychloroquine. So one of the other things that I think we're kind of moving towards in general in lupus is thinking about treating to target in lupus. And what that basically means is we're trying to get to a point where we have minimal or low disease activity, but also having low steroids at the same time. So it's not good enough to control disease, but have to be on really high doses of steroids. We want both. And we know that if we can achieve that, patients overall are less likely to go on and develop damage. So again, this is patients who had no or minimal disease activity, no major organ involvement, and were on less than 7.5 milligrams of prednisone half of the time, even at half of their visits to the clinic. They're much less likely to accumulate damage from their lupus over time. And this was a study we did in our own clinic. And we found that patients who were in that low disease activity and low prednisone for at least half of the time in their clinic visits were also less likely to have overall major cardiovascular events, so heart attacks, strokes, and or risk of dying from cardiovascular disease. So again, I think it's really important to think about, not only controlling traditional risk factors, also controlling inflammation in lupus, controlling disease activity, and also at the same time trying to minimize the amount of prednisone that you have to take overall. So again, in conclusion, we know that there is an increased risk of heart disease in patients with lupus. And I think, again, as we've talked about, there's a lot of different things that contribute to this. There's a combination of some of the traditional cardiac risk factors, but also some disease-related risk factors that contribute to this. And that includes inflammation and the amount of prednisone that we take, et cetera. So I think as patients, certainly make sure that you're sharing any information about heart problems or heart pain or chest pain with your doctors so that you can get evaluated. If you have chest pain when exercising, that's accompanied by any feelings of shortness of breath or sweating, definitely go in right away and get evaluated. And then, it's also important to, control all the things that we talked about, like blood pressure, any diet control that you can implement. Exercising, again, is hard, but always important. And then controlling cholesterol levels as well as lupus activity. So, I mentioned hydroxychloroquine. We also know that after you've been on hydroxychloroquine for a long time, there can be an increased risk of eye problems, et cetera. So I think one of the problems that we have in lupus is we don't know when it's okay to stop medications. And if you've been on hydroxychloroquine for 40 years, is it still giving you the same benefit if your disease is quiet as it was right at the start? So if anyone is interested, we're participating in a trial that's sponsored by the National Institutes of Health to see what happens when we discontinue hydroxychloroquine in patients who are in remission and over the age of 60. And we're also going to be looking, hopefully, at what that does to any cardiovascular risk factors as well. So if you have any interest in that, our coordinators, Lori and Ima, were sitting outside, and that you can grab some information at the desk, or you can contact any of us at this number as well. And so with that, I know a lot of patients in the audience have participated in some of our heart disease studies in the past, and we're ever so grateful for everybody who's participated in those studies. And then, of course, we have a huge team of collaborators, both at UCLA, but also at Cedars-Sinai with Dr. Wallace. And many of the lupus institutes have given us funding for some of our work too. So we really appreciate all of that. And with that, I can take any questions that you have.
Thank you so much, Dr. McMahon. So we'll start if anybody has questions in the room. We already have a couple that are streamed in. Anybody in the room? Raise your hand. No? All right, we're going to move to live stream.
Okay, so we wrote down a few questions. I'm gonna get where there's a little better light so I can see. So I can see a little better. First question, can an SLE patient develop multiple myeloma, currently smoldering myeloma?
I don't think there's any large scale studies about myeloma and lupus. I can say from personal experience that, again, we think about inflammation as being a trigger for some of that smoldering myeloma, and we have seen patients who have both lupus and myeloma. So again, it's important to kind of work with our hematology colleagues for screening that and trying to figure out how best to treat.
Another question is, should we be seeing a cardiologist in addition to a rheumatologist? Is that like a standard of care?
Yeah, I have a very low threshold for having patients also see cardiology. And I think, here at UCLA and at many of the centers, I know Cedars-Sinai also have cardiologists who have a special interest in rheumatology patients. And I think that we're going to, in the future, see more and more of these joint cardiology, rheumatology clinics or just working really closely together to kind of help make sure that everybody's getting treated appropriately and screened appropriately.
I think this one might go with similar to the previous question. Do you recommend your patients take a baby aspirin?
Yeah, that's a great question. Of course, it's going to be a little nuanced for every patient, and if you've had a history of, GI issues. But in general, yes, I do recommend a baby aspirin if there's any question about any other cardiac risk factors, hypertension, high cholesterol, like we've talked about. I think at that point, it's, benefit outweighs the risk of being on a baby aspirin. But of course, it's going to be a little different based on your background medications and things. And so I'd encourage you to always talk with your doctor first to make sure it's appropriate for you.
I think that was it from online. Oh, we have one more.
Hi, Dr. McMahon. Do you have any data about heart failure in lupus patients with post-COVID symptoms, vasospasm?
Yeah,
Vasospasm.
that's a great question. We don't have any specific data for heart issues post-COVID in lupus patients, but we do know that COVID can cause heart failure in anybody. And so certainly if a patient has had heart failure before, they could potentially be at increased risk. So again, if you have had COVID or developed COVID and you start having new symptoms, I'd encourage you to get checked out right away. Just to make sure that that's okay. I have a very low threshold for rechecking an echo or things like that if patients are having new symptoms after COVID.
Any other questions in the room after these questions? I had a feeling someone might.
Nicole.
Someone.
That discussed for lupus, would any of them falsely increase your blood pressure or just low?
Hold on, I'm gonna have you ask again because the interpreter can't hear. I'll bring you the mic. Thank
Hi, Dr. McMahon. Thank you for coming.
Mm-hmm.
Do any of the traditional medications that people are currently taking for lupus, would they falsely rise our blood pressure?
Yeah, I think the ones that come to mind the most would be from Dr. Grossman's talk, thinking about the calcineurin inhibitors. So some of those treatments for lupus kidney disease can cause an increase in your blood pressure. So if you're taking any of those medications, and I really want to see patients taking a record of their blood pressures at home, just so we make sure that we're keeping on top of that, because that can be an issue. I mean, otherwise, some of the things that we take for pain or inflammation, like nonsteroidal anti-inflammatories like ibuprofen, naproxen, et cetera, can also cause an increase in your blood pressure. So again, another thing to kind of, if that has changed for you, the amount that you're normally taking, might be good to let your doctor know, just so we can keep a closer eye on blood pressure, et cetera. And then the final thing I'll mention, a lot of the over-the-counter cold medications can also cause an increase in blood pressure. So if you're someone who's had some borderline blood pressure issues, you may even want to try to avoid those medications. But if you can't, again, keep a really close eye on your blood pressure while taking those. Mhm.
I think we have one more online.
Pardon my pronunciation on some of these words. Do you have any recommendations for meds for an SLE patient with LDLR genetic SNP? I'm on Repatha and has barely budged my LDLs.
Okay. Yeah, that's tricky, because I think that is the next generation. We talked a lot about statins. There are more advanced medications, like Repatha, but unfortunately, it doesn't sound like that's working for you. So I think, that's when you need to work closely with a cardiologist, because that's kind of an advanced case, of difficult to treat, high lipids. So, they may have some other tricks out there, but those would be the standard medications that we would generally go to.
Thank you. I think that's it for now.
Okay, great. Thanks, everybody.
Thank you so much.
We're just putting some chairs out. Thank you so much, Dr. McMahon. Okay, so we're going to have a panel discussion now. I'm excited to introduce you all to a few members of our Patient Advocacy Panel. We created this panel last year with a select group of patients, a select group of patient advocates. They not only share their personal journeys through the Lupus LA platform, but they also inspire and uplift others going through similar challenges. We have 6 women on this panel right now. Today, 2 will be joining us, and we're really excited to have Dr. Catherine Van Heijs moderating. Dr. Van Heijs is also a lupus patient. So ladies, whenever you're ready, please join us. I think they're here. Lorena, Tom, Vanya, and Ben. Guys, let us know we need to be more to the left. I want to make sure you guys are on the live stream. Are you okay there? Okay. Pardon me? Yeah, they need mics. Here you go. Here you go. Thank you so much. Thank you, ladies. Thanks for being here. Just push it and then the green will be go.
Okay.
There you go.
We're on. All right. Hi, everyone. I'm Catherine Van Heist. I am a fertility doctor. I just finished my fellowship training at Cedars last week. I'm also a lupus patient and have had symptoms for 3 years and had a diagnosis about 18 months ago. So my fellowship was a lot of learning what I intended to learn about fertility medicine, but also a lot of learning about lupus and navigating life as a lupus patient and all the challenges that go with it. So it's an honor to be here as sort of both a physician and a patient today. But yeah, I have a list of questions that we're going to go through from the top down. But if you guys want to talk about anything else, obviously, let me know. And if there's any questions from the audience that we can also incorporate beyond the questions they were giving us, then we can do that too. You want to say hello and introduce ourselves?
Hi. Hello. Hi, everyone. Thank you all for being here. My name is Lorena. Thank you, Lupus LA. Thank you, UCLA, and all the staff that's working to put this together. Thank you, guys.
Hi, everyone. I'm Vanya Zib. I am a lupus patient as well. I was diagnosed at CHLA at the age of 10, and I am now 30 years old. So I've been working very extensively with Lupus LA since I was a child. And they've grown to see me throughout my life with lupus and the different stages. So I'm happy to be here advocating upon children and adults today. Thank you.
All righty. So the first set of questions is about work-life balance with a chronic illness. So I'm sure we can all touch on that. But Vanya, how do you manage work when you're not feeling well? How do you know when to push, when to pause, take breaks?
Yes, for me specifically, I work in childcare. So I've had over 12 years experience working with infants, which I'm sure most of you know is very physically and mentally and emotionally exhausting. I've learned that I definitely need to listen to my body. There was a time during COVID where they had me alone with 12 infants under the age of 2, and they told me they are not allowed to touch each other. And I said, "You're insane." I would go home crying every night, telling my mother I'm never going to make her a grandmother because I was done with children. And physically, my stress, it made me flare up a lot. I had to learn that although I loved to do that, I needed to find a different outlet and how to do that and navigate my skills. I am now working with much older children, so it's not as physically demanding, but I'm still able to do what I love and use my skills and my passions of working with the youth to do that. So I definitely had to learn how to navigate my work in that way and changing it just a bit.
Wow. Were they understanding at times when you needed to take breaks or when you navigated away from the young infants to older kids?
At the time, my boss was, because she saw how brutal it was especially during the pandemic.
Yeah.
But it was also nobody was really wanting to work, so they needed me hands-on. But I needed to take a step back, even financially, that even though the money was great, I needed to take care of my health. Otherwise, I wasn't going to be able to work at all.
Mm-hmm.
So I definitely had to take a step back, which was hard because being diagnosed so young, I've always pushed myself so I could keep up with my friends and my peers and whatnot. So I felt if I give up, this is very diminishing myself. And I had to learn, no, I need to put that thought aside and I need to take care of myself. Otherwise, what good am I just laying in bed then? So I needed to learn to say no sometimes, and that was hard as a lupus patient.
It's really hard. I've struggled with that.
Yeah.
Lorena, as a young director, how do you manage work-life balance in your very high-pressure job?
That's a great question. I was diagnosed when I was 13, so it's very, very young. And one of the blessings out of being diagnosed at that age was learning from, early on that I was going to be my only advocate, really. I had to know my body. I had to know my limitations, and I had to be honest with myself and my doctor. And when I was 13, I was very keen on knowing, okay, like I will not let the lupus, diminish the dreams that I have wanted since I was a little girl, right? Which was to be a filmmaker. If anything, I was going to use it to my advantage and to make the lupus learn how to live with me, right? So with that being said, being on set for 13 hours, 14 hours is a toll on anyone, let alone when you have a chronic illness. But it's the place that makes me happy, where I get to be creative with a group of people who bring their talents and bring a vision to life. So I know that for those 3 days, 5 days, it's going to be tough. So I really try my best to like be in a good mental space before, and then really take time to recover, because it is a lot, but it's what I enjoy doing. But again, knowing your body and knowing when, okay, like I need to take my rest, or I need to just be in bed all day, right? And having a support system that understands that is very helpful. But I think it's, again, and being very communicative and being vulnerable and open to people so they understand what exactly is going on,
Yeah, definitely. Was it easy for you to share with your coworkers? Like, or how did you, or when did you, in the process of your employment, share you have lupus? And yeah, how did you go about that discussion?
I think it was, I mean, when I was first diagnosed, I felt like it was really no one's business, right? It was something, not that I had any shame, but I felt like no one, again, this is more than 15 years ago, so no one really knew what lupus was. And I didn't really feel like I had the energy to explain to every single person. But now, as I've gotten older, as I've hopefully gotten wiser, I feel like it is my responsibility, right, with as a patient living with lupus, to educate, to share my experience, and hopefully someone out there is able to resonate, right? And I think that's something that I wish I had growing up. I knew very little about the disease, so I know how important and imperative it is for people to share their stories and be vulnerable. And I've only used it really as a superpower, because I feel like even in my art, I'm very vulnerable. So might as well, like it's a part of me. It's not all of me, the lupus, but it's a part of me. So I should be open about it.
Yeah. We'll talk a little bit about vulnerability with the next section on relationships, but there was a question here about like how working in healthcare and how has that impacted lupus. And for my journey, I mean, I feel very similarly. When I was a resident, it was 12, 13-hour days were the norm, 6 days a week for 4 years. And so shortly after then is when I first developed my symptoms. And thankfully in fellowship, I don't have as long and strenuous hours that are expected of me. But your comment on like, when you know you have set days or long days coming up, I relate to that a lot with like, oh, I have this big exam or this big presentation. And so I feel it. I feel the stress build. I feel the lupus symptoms get worse. And I try and educate people around me, but it's been really hard to say no. That's been a learning curve. But I do think I've gotten better at that. So yeah, it's comforting to hear both of your stories and that there's some similarities there as well. Any other comments that you guys have on work-life balance and stress management?
I guess for me is, after a long stressful day, it's very important as a lupus patient to find some self-care time, going home, turning off the phone, turning off the laptop, whatever that is, putting on a funny movie, going to take a hot shower, something. It is very important for us to take that special and quiet time that we need on our bodies. And I know for me, sometimes I feel guilty taking that self-care, like, what do I have to complain about, kind of thing. People have it harder, whatever it is, or there's so much laundry I should be doing, but everyone will live with my laundry sitting there. It'll be fine. I need to take some time for myself. Otherwise, tomorrow I will feel it even worse. So, and then I'm not help to the children or my staff or anything. So that's very important. And you are not selfish for doing that.
Yeah, to piggyback on that, I think giving yourself grace, I think many times, yeah, we feel guilty, right? And that we have to do everything. Yeah, and that's, I think when you do live with a chronic illness, right, it's like a process of like this journey of self-exploration and learning to and get to that place where you can give yourself grace, because I think, yeah, that's super crucial and something that I know a lot of, it doesn't come easy for a lot of people, right, that want to keep going and have all these responsibilities and things they need to do, but your body will catch up to you sooner than later, right? So you might as well, you know, kind of pace yourself and not push yourself over the limit, because that's worse than just kind of like knowing, okay, I need a day to relax, to recover, disconnect, and kind of just look out for yourself.
I agree. Like I said, I graduated last week, and leading up to it, I just, I felt awful. And I was like, I know that this is the stress. And then I was in my head like, oh, well, I'm getting stressed. And so I'm making the lupus feel worse. And then it's just been such a journey of like self-exploration and learning to listen to your body. And that's one of the beautiful things about this, I think, for me, is like, oh, I can physically see stress happening to me within like an hour of feeling stressed. Like, oh, my legs will be more swollen, the malar rash will be more apparent. And I think as a clinician, that's a good reminder that stress really does impact all of our bodies, like in our physiology, very dramatically. And so I guess in a way I'm fortunate because I see it actually manifest visibly, but I think all as a society need to do better with our self-care and saying no and setting boundaries, because the best way to be the best version of ourselves at work or in life with our relationships is to take care of ourselves. So, yeah. If there's no other comments or questions about work-life balance, I think the next one is about relationships. So Vanya, you're a newlywed. Congratulations.
Thank you.
That's amazing. Yay. Tell me, how did you navigate dating? How was it like revealing all this with your spouse, and anything you'd like to share about that?
Yeah, so even started dating as a teenager. I had already been doing advocacy for a while, so I was very upfront about my lupus. Like, if you're dating me, this is part of the package. If you don't like it, there's the door. And a lot of them were like, yeah, no, that's fine, whatever. And once they got to see what it was living with someone, not even living, just still dating someone with lupus, that, oh, we can't go to the movies, my hands hurt a lot. Come to the couch with me as I'm heating up my hands with the heating pad. And sometimes they got bored, or that was boring to them or whatever. So it was like, okay, we're not a fit, this is part of my life. The man that I am now married with, he at a very young age was diagnosed with diabetes. So he very much resonated with what it's like to live with a chronic condition. And he was very understanding. If I had to text him last minute and say, I can't make it, I don't feel well, he was willing to come to me or say, no, take your time. We can watch the movie or go to this place later. And there was no guilt whatsoever. I didn't have to explain it to him. And he was also very willing to educate and learn about what this disease was because he had never heard of it. So he was very understanding. And I think that definitely doesn't mean you have to marry or date someone who also has a disease, but it does help at times for them to emotionally and literally get it because he did. And it was definitely hard dating people who I felt were a lot less mature because being diagnosed young, I had to grow up a lot faster than my generation. And I did not like what was out there maturity wise. So I was like, okay, yeah. So yeah, that definitely helped. And although we both battle with different diseases, we can be there for one another and sympathize, and we literally get it for each other. Yeah.
That's amazing. I'm so happy you found the one.
Thank you.
What about you, Lorena? Any insight, thoughts on dating or friendship, relationship, anything on when or how you choose to share your lupus diagnosis? And
I think it's very important to be open and share, even though it is like very vulnerable, but you know, in order for people to really understand, I think that's the only way is through communication, right? And the more that you can educate them, the more I feel like you'll have successful relationships where everything is very transparent and there could just be, you know, like you found, right? Like just understanding of this condition. And I think that's the only way, right? For successful relationships too, in any capacity, friendships, romantic, and, you know, in workspace and everything.
yeah. Yeah, I'm dating and it's been challenging, I have to say. And your comment on like, oh, maybe at first they're initially open to it, want to learn about it. That's great. I would hope that that's like a standard baseline for anyone. But yeah, I've had situations where it's been a little bit more involved. They've been there and then they've seen different parts of it and they're like, no, thank you. Like, this isn't for me. I've literally had guys be like, oh, you're damaged goods. So like, it's, I mean, yeah, but you just let it roll. Like you said, they're not the one for you. And so you just move on. But it is challenging to be vulnerable, I think, in like a dating setting, but making new friendships, disclosing it with coworkers. Yeah, it's been hard. Yeah.
No, I could definitely resonate with that. I've had a guy I was dating way before, and he told me it's too hard. And I was like, really? It's too hard for you. So,
Wow.
yeah. And so, yeah, I knew then it was like, yeah, this is definitely not the match for me. And,
Yeah.
you know, he was out the door. And 6 months later, he was calling, texting me, and I was like, no. Goodbye.
And I think also because our lives consist so much of, you know, going to the doctor, seeing different doctors, medications, all the things, right? It is important to have your partner be in the loop of all of that, right? And be able to be like a cheerleader or really supportive in your journey and helping, you know, you out.
Definitely. Lots of appointments, lots of self-care. Yeah. The comment you had made, Vanya, about like, oh, just I'm too tired today or I don't feel well today. Yeah, I've had a lot of conversations like that with family, friends, not so much with dating, but definitely where I've had very understanding, supportive friends where we've had plans to go on a trip and I just don't feel well and say, I can't come, I'm sorry. And in the beginning, there was a lot of guilt with that, but I think I've gotten better at not feeling as guilty, but that's something that we all need, and certainly with friends and partners. Yeah. Yeah. Any other thoughts, comments, questions on relationships?
Catherine?
Yeah.
Somebody online is asking, and it's not a, legal question, but for you ladies especially, you've all interviewed for jobs and you've all pursued work. Somebody is asking, at what point do you feel that you can share your lupus? Do you keep it private? Do you share it right up top? And that could be really for any relationship.
So all my symptoms started when I was at work, and obviously being a physician surrounded by physicians, there was a big deal of mystery about what was going on with me for quite some time. So my colleagues and I brainstormed collectively for about a year. So it was very open with me in the workplace. When I, interviewed for my new jobs as an attending, I didn't bring it up, but obviously if you Google my name, like I've done a podcast with Lupus LA, so they're going to see it. And it's not like I'm ashamed of it. If anything, I think it's a benefit that you have a physician who has a really good understanding of what it's like to be a patient as part of the team. But no, I don't like go into interviews and be like, hi, I'm Catherine, I have lupus, but but I certainly am happy to talk about it. And I mean, like my professional interests, I think have started to overlap with lupus and just autoimmune disease in general. Like my research thesis for my fellowship was about immunologic disease. And so I have gravitated towards that naturally. But yeah, with dating, I'm working on being better about like being more open and transparent in the beginning, because otherwise it's just a waste of time. If I try and be secretive and then, we need to be on the same page in the beginning. But with work, I'm open to share, but I don't advertise it in interviews.
Yeah, I would say in relationships, there has to be some trust, right? Like once I feel like, okay, like you've earned my trust, I will, open up about this part of my life. And at work, again, not in the beginning, right? But I do want to be transparent, because there might be certain limitations, right, that you might need in your workplace. So it's better for them to know what's going on, and not that you need, that you're trying to be special or do anything, but these are the accommodations I need. So I would, if you feel comfortable, obviously, bring it up.
Yeah, I would definitely agree with both of you ladies. Yeah, I don't usually say it right in the beginning, but I do eventually say it, especially once I've gained the trust of my supervisor, my boss, or the director of the school that I work at. I'll definitely let them know. And I would hope that they would see what a hardworking person I am, even on my good days or my meh days. They see that I'm not faking it, and that when I am asking not to do as much, or I can't really be picking up so many toys today because it hurts everything, that they understand why and whatnot. And yeah, I don't want to be labeled as you're just using the sick card kind of thing. So I definitely only use it. And if I do use it, once they know Vanya, they know that, yeah, she only uses that when she's really isn't feeling well. And it's a trust that goes both ways. Once they've trusted me, I can trust them with that. But I definitely do say it at some point, because I think it is important. And most, at least in my experience, most, if they don't know what that is, they do ask, and they are wanting to know, oh, what is that? And how can we help you? And I think it also says something big in the workplace. If they are disgusted or just not empathetic about it, maybe that's not the environment for you, and that's okay. Maybe it's time to move on, because that definitely makes a difference in you wanting to go into work every day and work hard, and maybe push yourself even harder, even though when you're going to feel crappy later about it. But because your boss is so understanding on those other days, it makes you a much better employee or helper or worker. Yeah.
Does anybody in the room want to add anything? Does anybody want to participate, share anything?
So I'm having a problem dealing with family and friends who say I'm using the sick card. You're not the same person you were, Sometimes I just don't have the energy feel guilty, try it, and I'm just miserable and in pain. When I'm at home alone, I'm in pain. So how do you make them understand that, no, they won't come to a conference with me. They won't look it up. It's like they either ignore it or you're not that sick. You've always been the one that does everything and da, da, da. Why can't you? I don't have the energy. I just can't. So I'm getting to the point of ignoring phone, but then I get these texts. What did I do to you? I mean, it's not about you. And I'm trying not to absorb that because I've got enough trying to struggle day to day to deal with all of my illness and all of the side effects and everything else. So I don't really know how to handle it except for I'm pulling back.
Go ahead.
Well, we're all here. This whole room has your back. We're here for you. I would say with a lot of compassion, right? This is, this is what I have. This is why I feel like I can't partake, or I would love to, but I'm feeling this. And if they don't understand, I mean, there's really nothing you can do, right? You've tried with love to explain your situation and it's like a two-way street, right? That's what you say, like a two-way street, right? Like you're giving and they have to put their, they have to come in and be want to
Family and my that I don't want to do, but I'm starting to do.
yeah, but it's you, right? You're still you. Nothing has changed. Your limitations may have changed, but you're still you. And I mean, this is like the part where your friends are supposed to show up, right? This is where they show up and they're like, we're here for you.
I have one advocate and I'll call her and say, please. And she'll call and try to explain and because she understands. She's, kind of been there with cancer and other family. And she tries to explain, but you realize how selfish people are. They don't care. It's about them. And that really makes me feel sad.
I agree. Well, I agree as well. I think most of us have experienced that at least once. Lupus definitely comes to show you who's really there for you at the end of the day. And it sometimes, unfortunately, is not our blood relatives. It's not your own mother. It's not your own father. It's not your own, your children that you grew up. Sometimes it's just the random neighbor in the front or the nice lady at the grocery store, whatever it is, but at least somebody's there and is understanding. I had a family friend that literally was there at the hospital with me while I was in a coma, and she was there throughout all these years. And once we got older, she said, I'm tired of the lupus thing. So even people who were there for you can change, and that's them. That's not you. You didn't ask for this and you didn't change. Like she said, you didn't change. And it's not on you, it's them. And people like to portray that as a reflection that we're the problem. And we're already dealing with a lot more than half the world is. So you don't need more on your plate. And honestly, sometimes it's a blessing to discard those people, because why do you need that extra burden of those calls, that extra stress in your life? You have enough on your plate.
That energy. You just
Yeah.
need good energy to
Yeah.
keep you healthy.
Yeah.
Protect your
And
peace.
I'll say that one of the things that we hear from our support groups a lot is that, there's a sense of community. And so if you're not finding it within your own community, I mean, even if you are, that this is patient run and a space for you to feel that you can share and get support. Anya, you're a part of a regular support group.
And I think stepping away from even our loved ones for a minute or two is good. I think that our family members also suffer when they see us suffering. And if we need that space for a little bit, I think it's a great thing to do for us lupus patients. I can tell you that I've gone through the same thing. I have had friends that I had for a very long time. And when they didn't understand why I couldn't make it to their birthday party, to an event that they had, it was something against me. So I stepped away. Now they're still my close friends, but I know when and when not to talk to them. Now, if it's affecting my well-being or my mental health because I feel that they're not understanding, then stepping away is okay.
I think yeah, you have to be really brave. And I've struggled with this, but setting boundaries with people that you love and saying, no, I can't be there for you at this time. I need to be here for me. And I've really tried to embrace, like, I'm protecting my well-being and I'm protecting my peace so that when I am with you, I'm fully present and I can give you my whole self. But when I'm saying I need my time, it's for my own well-being, which is for the collective well-being of us and our relationship. But it's really hard.
And for our friend over there, also maybe you're saying that your friends and family aren't maybe understanding or they don't know. I mean, granted, it's very tough to understand something that isn't so visual. It's more internal. So if you're okay with it, I would suggest maybe inviting them over when you're not feeling too hot so that they can maybe see the swelling or see the pain and know that you're not fooling around and you're not, you know, just wanting to stay home. It's kind of like a necessity for you to heal and feel better so that then you can just A, show up for yourself and be there and take care of yourself. And then B, hang out with them next time or some other time, if that's okay with you and if they're, you know, in a reasonable distance to come visit. So that's, I think, my suggestion because my sister, I know her, I know that cool kid in the middle. That's my sister. And granted, we didn't know what lupus was in the beginning, but with support groups and research and all these things over the years, I was able to understand better and then was able to better understand her and help her. And to the point where we have to slow her down because she goes full force all the time until she's in complete pain and aching. So now being able to read those symptoms and kind of seeing it in advance or knowing what like those limitations would be. Granted, they always change and they're always seasonal and nothing's ever set in stone. But being there for her and icing her down or just like telling her to like, I guess she got lucky this time again with the chores and things like this, you know, growing up. But I forgot what my point was, but essentially we have to slow her down and have her like cool off. But I think she's learning how to read her body in like recent years. So yeah, we're proud of her and I think you're going to be great. You've got a great set of people here for you. So.
And you're an amazing as a brother. You're there, you're coming here and learning about it, and you're always with her and supportive. It's really beautiful to see.
I've always wanted a kid sister when I was a kid. So once I had her, it was like the best thing ever. And then once she was diagnosed with lupus, it was really, really tough on the family. And I'll share this with everyone because I think everyone should hear this. And I've never really said this out loud, but I was a late teenager, so I was going through my own things and trying to figure myself out. My sister was like a young 12-year-old or something, right? You're like 13. So she's just becoming a teenager, dealing with her things. And I obviously, not knowing what lupus was at all and being frightened, I couldn't share that with my single mother raising 2 kids. So I was going through my things, trying to figure life out, trying to figure out like what this lupus thing is. Maybe it's maybe it's something like a cold or something where it'll go away. I'm not realizing the severity of it. But once I was more educated on it, it took me like a couple years to come around and realize it ain't going anywhere. So I better step up once again in a different way. Because after my mom divorced, I had to step up and be the man in the house and do that kind of thing, and wanting to be her older brother and step into shoes that weren't there. But then I had to also kind of think of it as like a caretaker. But I loved it because I wouldn't change anything. And then as we've grown up together and as our relationship has evolved, we became business partners and we became artists together, and we just have become collaborators, and we're not just brother and sister. We're just, we're friends and support systems. So I think that everyone can have that too. If you're just open about it and find the right people, find your tribe.
Thank you for sharing. Are there any other comments, questions from the audience? No? Oh, one more.
My question is, what do you know now about navigating lupus, managing symptoms, managing relationships, both personal and professional, that you didn't know 2 years ago, 5 years ago, 10 years ago? Like, what are your top lessons?
I think mine is like saying no. Like I gave this example to somebody recently, but when my symptoms first started, I was in the ER as a patient and I was still charting on other patients' charts while I was in the hospital. And I was admitted to the hospital overnight, had telemetry monitors on, and I was still on call. And I was too afraid to say, I'm in the hospital. Can somebody please take my call? And I mean, that's not to say that my colleagues, would have forced that on me. Like, I'm not trying to call anybody out here. They have been very supportive, but it's just like internally, I really struggled to ask for help in the beginning. And so it's taken a lot of time and a lot of just practice at saying no, setting boundaries. And I think that's been the most helpful in my personal and professional relationships, is setting boundaries, which is a lot of giving yourself grace, which we've talked about.
Yeah, I would say the same thing, saying no. It's super powerful, but it feels weird at first, especially when since you were a kid, you just, it's like the Energizer Bunny, you just go, 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 and you want to do everything. And having grace with yourself, right? Having grace with yourself, that took a while, because I always just felt guilty. But again, having been diagnosed at 13, which at that moment in time, it felt awful to be that age and have had this diagnosis, because I was still trying to like come into myself and like know myself, knowing and listening to my body. I think that's gotten better over the years. It's more clear to me. And I think that's crucial for any patient of any condition, to know, for it to kind of become like just like a intuition, innate thing. So you can set those limitation and those boundaries, right? And know, okay, like I need to slow down and pace myself, because I can feel that I'm kind of going, over the edge here. So I think those have been the things that, as I've gotten older, have become more clear to me, and I'm, yeah.
Yeah, for me, I would say the big lesson would be nobody knows your body better than you. I've had times where even my family and I had to learn this, that because we see a doctor in front of us, we take all their information. And although they know a lot, and I completely respect them and follow their advice, I'm the one that goes home with this disease and lives with it day in and day out. And I see what it is every day. And not every case is the same. So I may be the exception or whatever. I had a time in my life where my lupus was in remission, but I was still in horrendous pain. And I was already living with lupus for over 15 years and knew how to navigate my pain, but this pain was completely different. And the doctor said, "You're fine. Your lupus is under control. You're fine." And I was taking an opioid almost every day because that's how bad the pain was. And they kept saying, "Your labs, your numbers, they're fine." Turns out I had fibromyalgia. And if I hadn't listened to my own body, then they would have probably just kept me quiet and I would have kept living in pain because technically I'm fine. So nobody knows your body better than you. Listen to it. If you feel something's off, it's most likely something's off. I learned that that was not lupus pain. This was something else. And it turns out it was something else.
Thank you for sharing that. That's a good segue, I think, into the final set of questions. And yeah, one I feel really passionately about as well, but advocating for yourself in the medical setting and knowing your body best. So what did you do in that situation when your doctors just kept saying everything is fine? Did you go and get a second opinion, or what advice would you have for anybody that feels like they're being dismissed or not listened to?
Yeah, yes, we went to a different ER. And the doctors there at the ER, they saw my history and they were like, okay, so it seems like everything's fine there. They said it is rare, but we do sometimes, like 10% do see children get fibromyalgia. And they explained what that was. It's excessive nerve pain when your nerves are just going whack. And even laying in bed hurts. It feels like a truck ran over you. So they went ahead and tested me for that, and I blew the charts right off the roof. I was 100%
Wow.
had fibromyalgia, and once I was 6 months into treatment, the pain has gone away, and I haven't touched anything stronger than Tylenol in over 12 years.
Wow.
And if I hadn't listened to that and my gut of, I know what lupus is, and this is not lupus, then I would have probably still been called crazy and just been at the ER asking, "Help me, help me." So we need to listen to ourselves. We know.
You have any thoughts? Yeah.
Yeah, I remember when I was 12, like I grew up playing basketball, so I was very athletic, and my joints started hurting out of nowhere, which was very weird and odd. And then I would get these rashes on my legs, and I became super sensitive to the sun after playing outside, every day. And I was like, well, something's up. And I went to my pediatrician at the time, and he kind of dismissed it until I came back again. And then it was like, oh, maybe it's something else, rheumatic fever, like didn't do anything. And it wasn't until my mom had found a doctor, and we had gone to Columbia Presbyterian to see a rheumatologist. And sure enough, just telling her all my symptoms and what I was feeling, and she did the blood work to confirm that's how I got diagnosed. But it was quick, relatively speaking, compared to other diagnoses that take a long time. So I feel very lucky in those regards. But she was able to diagnose me, and then knowing then and there that this doctor I was gonna be my own advocate, right? But I had to trust this doctor, and I was gonna be super open with them, and I would go in with questions and everything, and bless her heart, she answered everything, and it was like a team, and I felt very lucky that I had seen her till like my early 20s, and then I came to UCLA when I moved to LA, and I had been under the care of Dr. Grossman, and it's been the same thing where, again, it's like a give and take, right? I ask questions, and I try to, if she's going to put me on certain things, like why, like what are our options here? And it's like a tag teaming. And I think that has been the success. And again, I think that's a crucial relationship in this journey is because you are your best advocate, right? And you know your body the best. It's being able to translate that, and hopefully the doctor can,
Yeah.
take that and
Yeah, I think it has to be the right match. I respectfully asked my first rheumatologist for a second opinion, and that's how I found Dr. Wallace, and he's the one that gave me the diagnosis. So it's been a crazy experience to be a physician in my own institution and still sort of struggle to find the diagnosis and find the care team that was working for me. So it's really been eye-opening there's a lot of room for improvement. I think the tangible things you guys mentioned, like I go to all my appointments with long lists of questions. I'll bring papers that I read about on the internet just to pick their brain. And I think as long as you do it with respect and there's mutual respect, I think that's, very appropriate.
I actually was very similarly to you guys, was diagnosed by a second opinion. I was also going in and out of pediatric doctors. The age of 10, at the time I was very into tetherball, and my joints in my hands started hurting. So I stopped playing that sport, but the pain continued, and the doctors just kept saying it was growing pain because I was almost in my preteen years. So they said, she's just growing. But my mom knew that's not her child, that this was something else. Because I stopped playing, I stopped eating, I stopped watching cartoons. And she's like, no, this is different. This is not pain like that. So we eventually, the lady in the front office, she already knew us by name and she already knew us. We had gone there so much. She said, let me refer you to an elderly care doctor who only sees elderly patients. He agreed to see us after hours. So once the clinic closed, and he took one look at me, heard what my mom was saying as well. And he said, this is lupus. And we got referred to the emergency room of Children's Hospital. And he was just shaking his head like, these people, how can they not see it?
Wow.
I got admitted that night, and the doctors were just astounded with how much damage was in my body. A week later, I had a seizure, landed me in a coma for a week. When I woke up from that coma, my memory was gone. At 10 years old, I was a newborn. I had to learn how to walk, talk, and learn I had lupus. And if my mother had not listened to her instincts, knowing this is not
right,
who knows what would have happened, because that happened within the best care at Children's Hospital. If I was still sitting at home, I don't know I'd be here today talking to you wonderful people. So it is very important. If you need to get a second opinion, it saved my life.
Thank you for sharing.
Ladies, thank you so much for being vulnerable, for sharing everything. Anybody in the room have any comments or questions? If not, okay.
Thank you. Vanya, I'm extremely curious. Once you were diagnosed with fibromyalgia, how did you get rid of it and no more symptoms?
Yes, I had to become very active. The doctors were they were very particular about how active. So definitely not running. The pounding on your joints kind of activity was not recommended. So I had to take a lot of swimming and doing massage therapy. I was on Lyrica for around 6 years until I slowly got off of it. That definitely made the pain lessen. And I also learned my triggers. My fibro would definitely stress related, would flare up. So, and I had to learn my diet too. If I had amounts of sugar or fast food, my pain would increase. So I had to learn about my body a lot. I had to learn that I could not be so maybe physically demanding like my peers were. I could not be out and about till 10 p.m. hanging out and whatnot. Sleep, very, very important. I had to sleep in and miss out on a few things, but the sleep made it immensely important. Learning that heat or cold really helped in the areas that were pain. For me, the fibro was mostly in my back. So a heating pad became my best friend in the world. I got one of those giant ones and it was my best friend everywhere I went. To this day, I still have like 3 in like every room, one in the living room, one in the kitchen, one here, there. So it's definitely learning, yeah. Taking hot showers definitely helped. And when you need it, yeah, take your medicine for pain and not feeling guilty about that. Some days you just need it. Also, weather. For me personally, when it's rainy, my mom calls me the best weatherman. I can feel it in my back if it's going to rain. The pressure within the atmosphere, I feel it on my body and my joints, and I could feel that, and that definitely would spike my pain. So, although you can't control the weather, but preparing for that and maybe not planning to do crazy things like going to Disneyland or going to the mall that day is probably not the best. So maybe doing a low-key day or staying in would be recommended.
Ladies, we have a question from a live stream. Lorraine, I think this is going to be close to you. I think I heard someone in the was in the entertainment industry. If so, wondering if you told your bosses at any point. Also, can you expand on how you really deal with 14-hour days to take care of yourself, especially when they happen a couple of days in a row?
I feel like it's important to share, right, with my bosses or with my fellow producers, so they have some understanding of what's going on in here, and again, the trust. In order, like making something a film, especially, is such a process, and there's so many people involved. So you want to be able to give 120%. And with those long days, I mean, I feel it in my joints and I need rest, right? That's important, but making sure that I do manage to get my rest and minimize the stress as much as possible, even though sometimes that's impossible. But having people that you can delegate things to. I have incredible producers like my brother and like my other fellow collaborators, where it's like, okay, you have to deal with this because I can't, physically I can't, mentally I can't. I just need to kind of what's the word? Self-conservation? No. Yeah.
Self-preservation?
Yes, self-preservation. You have to go into that mode, right? Because you need to last until the end. And you have to give your best till the end. And you have to be there for your actors. But I think when people see that and they see how open and vulnerable you're feeling, I mean, that's the environment I would want to be in, and create a safe environment where everyone is, because everyone is being vulnerable, whether they know it or not, because it's art that we're putting together. So I think that's crucial for just like a healthy, soul, mind, body, and soul, like atmosphere for everyone to be give their best.
And I would ask the three of you, as women who are in the workforce, do you feel that your own situation makes you more compassionate bosses, coworkers, employees?
Yes. It's the short answer. Yeah, I think so. When when this all first started, one of my best friends and coworkers kept saying, like, everyone has something, Catherine, like we learn that we have to just show grace to ourselves and be kind to others. And I think that it's a reminder for everyone that you don't always know what's going on in someone's life. And a lot of things with lupus, you might not be able to see. And so just be kind to yourself and be kind to other people. And I really don't think it's that hard to be kind, but for some reason, I don't know. I think as a society could improve on it. So it starts with you as an individual. So I think I try and lead with kindness in the workplace and be compassionate because everybody has something.
Yeah, 100% the compassion. And again, you don't know what everyone is going through, right? Lupus is one of those invisible conditions. So there are so many other ones, right, that people are going through. So I think if you lead with love and kindness and compassion towards others, then yeah, this world would be a better place for sure.
I would say absolutely. Working with children and now working with special education, high schoolers, I definitely can resonate, and a lot of them dealing with different disabilities and learning disabilities, physical and mental and emotional. I can't be in their shoes and know exactly what they're going through, but I can definitely resonate with them. Missing school, having doctor's appointments, their parents being annoying because they have to take this and take that and whatnot. But also the bullying that goes on in school, the struggles they have with their memory. Because of my coma, I did struggle with memory and taking the special classes. They don't like it because others are wondering, why do you have to go to this class and that class? Why do you get extra time on tests? And I definitely just resonate with them a lot, and I can be more patient with them when they're acting out and whatnot, because I understand that these kids are going through different things, and just as I was, and I want to be that educator and teacher that I also had at that time that helped me. I want to be that teacher for them now and pass it on.
Thank you so much, ladies. I know you all inspire me. We appreciate you being vulnerable and sharing your stories with the community. And we thank everybody for coming today. We're going to do the raffle. I'm going to have Mia come up, and you ladies, if you want to participate, you can draw a winner. There's 3 raffles. There's 3 of you. So you can just hang out for a sec.
Hi, everyone. Thank you so much. We're going to do a drawing of 3 winners in the room. We also have one at our online audience that we'll follow up with after the conference. We will email you at your registered email address. But for now, in the room, our first number is ending in 036. 036. Oh,
woo, woo.
Okay, and our next winner, 023. 023. There we go. And the final number is 043. There we go. Congratulations. Also, if anyone has a completed survey, you can give it to a member of our staff, our volunteers, or we left a basket in the front where you can just drop it off. And we appreciate your time and your participation.
Yeah, thanks for coming, everyone. Thanks for coming online and participating in the live stream. Thank you for being here in person. If you have any questions, you want to reach any of the doctors, we're going to be able to share the PowerPoints. So we'll put that all up when we put up the recording. And then you can always email us at info@lupusla.org if you have any questions. Thank you so much. Thank you guys. Thank you so much. I want to take a picture with you guys outside for the photo. Thank you for doing that. You got your brother and he's calling. That's the one to see you.